See, you have the hemoglobin in two forms. One is the Fe3 plus and second is the Fe2 plus. Okay. Fe2 plus can bind readily with the oxygen, but not this Fe3 plus. So what happens is the hemoglobin get oxidized into the Fe3 plus form, and as a result, it now cannot bind with the oxygen. So it becomes the methemoglobin. Okay, but please note that this oxidized hemoglobin has a very higher affinity for the cyanide. So it instantly binds with the cyanide. So this condition, this methemoglobin can be also used in the treatment of cyanide poisoning. Okay, so now what happens is, now because of the oxidization, the affinity for, this hemoglobin now cannot bind with the oxygen. So as a result, the total saturation of the hemoglobin with this oxygen will be decreased, and the total content of the oxygen will be reduced. But the dissolved content will absolutely remains normal. So hemoglobin concentration will be normal, saturation will be decreased, total content will be decreased, but the dissolved oxygen will remains normal, right? Now, with this methemoglobinemia, what you will have is a cyanosis in the blood. Your fingers, your fingertips, your lips, they will all turn blue. Patient will have a chocolate colored blood. So when you take the blood sample of the patient, you will find that the patient is having a chocolatey colored blood. So these two things will be present in the methemoglobinemia. Now, because you're having a very low this content of the oxygen, what you will ultimately having is a tissue hypoxia. Okay, the lactic acid will be increased as a result, because the non-oxidative respiration will be activated. Okay, so lactic acid again will be increased in the patient. The patient would also be having a high anion gap metabolic acidosis. Okay, and that's all because the hemoglobin is now oxidized into Fe3 plus, which cannot be bind with the oxygen now. This can happen with the nitrates. Okay, nitrates can do that. That can be happen with uphalted water sources or from dietary intakes. Local anesthetics like the benzocaine can also do that. Okay, they will all be causing this condition via oxidation of the hemoglobin. Now, this condition would be treated with the help of methylene blue and vitamin C. If you guys go back to the biochemistry, we have discussed that the vitamin C will convert this Fe3 plus into the Fe2 plus form. Remember?
Yeah.
And now this Fe2 plus could be easily absorbed in the GIT also, right?
Right.
So again, this methemoglobin could be treated with the help of vitamin C. Okay. Now, even if you give the patient supplemental, the very important thing, even if you give the patient supplemental oxygen, this won't raise the saturation of the patient. See, if this is a normal anatomical defect, for maybe because of any case of embolism, for example, or maybe any case of obstruction in the airway passage, in that case, the saturation of the oxygen with the hemoglobin is also decreased, right? But if you give the patient supplemental oxygen, that at some point this supplemental oxygen will correct the conditions if there's any kind of anatomical defect present. But because this methemoglobin cannot bind to the oxygen at all now, even if you give the patient supplemental oxygen, this won't raise the saturation of the patient. Okay. So note this fact, it is very important. Similarly, if you give the patient aspirin, for example, any kind of aspiration, for example, happens, this will cause a blockage in the respiratory tract, right?
Yes.
If this respiratory tract is blocked, the air cannot reach to the alveoli. Now, as a result, all of that blood will go unoxidated, right?
Right.
So as a result, you will see that that this overall saturation of the hemoglobin with the oxygen, it will decrease now, right?
Yes.
But if you give the patient supplemental oxygen, then those other areas where the oxygen is kind of less, they will get the 100% oxygen now, and as a result, the hemoglobin there will become more saturated with this oxygen, right?
Yes.
So this will somewhat increase the saturation. So by giving supplemental oxygen, you can correct the anatomical defects, but you cannot correct this methemoglobin by giving the patient supplemental oxygen. So this is a very important hint. Step one, this vignettes will tell you that even after giving the patient supplemental oxygen, the saturation level of the patient was again lower than the normal, still not raised. So this will give you the fact that the patient is having a methemoglobin. This will help you determining the cause. Okay. So any doubt about this methemoglobin?
No, thank you.
Doctor,
Yeah.
how can we induce the methemoglobin and cyanide toxicity? How does that work?
How can we induce? By anything that could cause our Fe2 plus to be converted into Fe3 plus. Any oxidizing agent can do that. Reactive oxygen species, for example, they can do that.
No, I guess we treat the cyanide toxicity by inducing methemoglobinemia, right?
Yes.
How that works
You
exactly?
directly give the Fe3 plus form in the patient. You will inject this Fe3 plus hemoglobin directly.
Okay, but that will worse the hypoxia, right?
This see what happens in the cyanide poisoning is the major thing is you cannot use your complex. Remember the ETS, the electron
Sorry.
transport system complex 4. Remember?
Yes.
See what
Yes.
happens is the real cause of the cyanide poisoning. How this is affecting your body is because it causes the blockage of this complex 4. Now, as a result, your cells cannot use the oxygen. Even if they use the oxygen because ETS is inhibited, they cannot use it, right?
Okay.
So the oxygen is available, it just cannot utilize by your cells because cells are, this complex 4 is not inhibited. So the oxygen is there, but the cells cannot use it. If you give the patient methemoglobin, the cyanide will get bind to this this methemoglobin, and ultimately cells can now use the oxygen.
Yeah, it will release the complex factor 4.
So this one, see, you either can have 1 or you can have 0, and 1 is always better than having a 0 thing, right?
Yes. Yes.
So slight oxygen will be available to the tissues for the use, and now they can thrive on that, right? But in case of your cyanide poisoning, sorry, in case of the cyanide poisoning, your tissues cannot utilize oxygen at all. Absolute 0, for example, right? So that's how it works.
Thank you.
Okay. So this methemoglobin, you will have the oxidation of the hemoglobin, and that would be converted into the Fe3 plus form. This Fe3 plus form cannot bind to the oxygen, but it can bind with the cyanide. So that's why it is useful for the cyanide poisonings. And please note the examples which can cause the methemoglobin in your body. Nitrites can do that, benzocaines can do that. Okay, and anything which oxidizes the Fe2 plus into the Fe3 plus can do that. And one more condition, one hereditary condition, in which the patient has a deficiency of the NADPH methemoglobin reductase. See, the function of this enzyme is to cause the reduction in the Fe3 plus to Fe2 plus, this Fe2 plus. If the patient got a congenital deficiency of this enzyme, they can never convert this Fe3 plus into the Fe2 plus, and as a result, they will be at an increased risk of getting the methemoglobin. So again, this enzyme deficiency can also cause this methemoglobinemia. Is that okay?
Yes.
So remember this hereditary condition also, multiple patient membranes, multiple members of the patient family can have the history of this such kind of a disease. So that will help you knowing this thing that this could be due to a congenital the deficiency of this hemoglobin. Okay.
Yes.
So for the methemoglobin, look for the examination of the patient. If the patient's lungs are absolutely clear on the auscultation, no kind of aspiratory history is present, no kind of mechanical obstruction is present, and giving supplemental oxygen, the patient is not having a this elevation of the saturation, that's how you know that the patient is having a methemoglobin, not some other kind of anatomical defect. Then you have the oxygen hemoglobin dissociation curve, and I already told you why this curve is sigmoid shape. Remember?
Positive cooperativity.
Yeah, because what happens is whenever one molecule of the oxygen binds to the hemoglobin, it will raises the affinity of next hemoglobin molecule to bind with the oxygen. And as a result, when this affinity increases, you will see this kind of a slope. And when all of the hemoglobin got saturated with the oxygen, the saturation, this affinity again start dropping, as you can see. Right. So this kind of a sigmoid curve is formed whenever the oxygen binds with the hemoglobin. Shifting this curve, see, you have a P50 value. That means, the partial pressure of the oxygen at which the hemoglobin is 50% saturated. I told you, although we don't have this we don't have to measure this PaO2 much often, but you will use this PaO2 in order to find the saturation of the hemoglobin, right?
Yes.
So you see the partial pressure of the hemoglobin, the partial pressure of the oxygen at which the hemoglobin is 50% binded with the oxygen, you call it a P50 levels. Okay. So if you have, if you require more oxygen for the 50% hemoglobin to bind with the oxygen, would you call it a high affinity or a low affinity?
Low.
Exactly. So see, if you have a right shift, okay, if you have a right shift, that means at higher level of this PO2, okay, at higher partial pressure of this PO2, you're having a same saturation, versus with the left shift at lower level, a lower partial pressure of the oxygen, you're having the same saturation, right? So that means with the right shift, I got a low affinity. With the left shift, I get a high affinity. Is that okay?
Yeah.
So any condition which will be shifting the curve to the right will causing a low affinity with the oxygen, or any condition which is shifting my curve towards the left will making a high affinity for my hemoglobin. So you have two shifts, right shifts and the left shift. Causes for the left shift include acidity. If you're having a high pH, which could be metabolic acidosis or respiratory acidosis, which means a low pH, a high PCO2, okay, or any case of hypercarbia can cause it. Exercise can cause it, because with the exercise you need a more hemoglobin to be dissociated from the oxygen, so that this oxygen could be dissociated from my hemoglobin and can be utilized by the tissues. So exercise can do that. Having a high level of 2,3 BPG, and that what you will find in the tissue sites causes the right shift. High altitude will cause the right shift, and high temperature will cause the right shift. Again, in the sickle cell anemia, you can have all these things also. With the right shift, because the affinity of the hemoglobin for the oxygen is decreasing, that means the oxygen can easily be unloaded now.
Yes.
Right.
So this kind of a hemoglobin, which is in the right shift, it will easily release the oxygen so that the tissues can easily utilize this oxygen. So with every right shift, more unloading of this oxygen will occur, so that more tissues can utilize this oxygen now. With the left shifts, again, you will be having a high affinity, and as a result, it will become very harder to dissociate the oxygen from the hemoglobin. Okay. So the causes include the alkalosis, respiratory or metabolic alkalosis, low level of carbon dioxide in the blood, low level of 2,3 BPG, which exactly what you will find in the tissues, in the lung sites. Okay. Low temperature can promote more binding of the oxygen with the hemoglobin. High level of carbon monoxide, I told you that this carbon monoxide competes with the hemoglobin for the binding sites, and will cause a decrease in the binding of oxygen with the hemoglobin. But at the same time, it will also be increasing the affinity of my oxygen for the hemoglobin, right?
Right.
And as a result, because the affinity is now increased, it will become very much harder to release the oxygen at the tissue sites. So in case of carbon monoxide poisoning, first thing, you're having a low level of this oxygen in the blood. And second thing, whatever the oxygen levels are present, now the tissues cannot utilize this, because the hemoglobin will not release this oxygen, right? On the tissues, right?
Right.
So again, this condition. Now, methemoglobin can also cause it whenever you have a methemoglobinemia. Okay, although this hemoglobin cannot bind to the oxygen at all, but it will increase the affinity of the hemoglobin to bind with the oxygen. So whatever the hemoglobin is already binded with the oxygen, it won't release it. So again, creating the hypoxic environment in my tissues. Fetal hemoglobin has a very high affinity for the oxygen, and I told you this will help the fetus to extract the oxygen from the mother's blood, right?
Yeah.
So this condition again. So all of these conditions will promote the affinity of the hemoglobin for the oxygen, and as a result, the release of the oxygen by the hemoglobin will be decreased. So if the release of the hemoglobin for the so if the release of the hemoglobin by the oxygen is now decreased, can my tissues have the hypoxia now? If the release of
Yes.
oxygen by the hemoglobin is now decreased, can the tissues be having a hypoxia?
Yes.
And because they're having a hypoxia, similarly, the kidneys can also be in the hypoxic conditions. that will cause the release of the erythropoietin, and this will cause the compensatory erythrocytosis. Note this fact, very important. We will again discuss the same thing in case of exercise and in case of high this altitude. So know this thing for now, okay?
Yes.
Other than this fetal hemoglobin and the adult hemoglobin, you also have the myoglobin, okay? And this myoglobin, it has only one hemoglobin, not the four, but only one hemoglobin. And as a result, it won't show any hemoglobin-induced hemoglobin saturation or affinity, right?
Right.
Heme interaction does not occur, so you won't get any sigmoid shape in this curve. And please note, myoglobin has the highest affinity for the oxygen, even more than the fetal hemoglobin. So highest myoglobin, then second highest fetal hemoglobin, and finally the adult hemoglobin. Okay.
Yes.
So that was all on this paragraph. Any doubt on this page?
No, thank you.
Sorry, could you
Yeah.
please once explain how the pH do right shift, because I lost the connection.
Whenever you have an acidic pH or a high level of H plus ions, metabolic this acidosis or respiratory acidosis, this will promote the unloading of the oxygen in the tissues. Okay, this will decrease the affinity of my hemoglobin for the oxygen, and as a result, the hemoglobin will be easily releasing the oxygen at the tissue sites. Okay. Similarly,
Okay.
if you're having an alkaline pH, means low, this means low H plus or a metabolic alkalosis or a respiratory alkalosis, this will increases the affinity of the oxygen for the hemoglobin, and as a result, the unloading of the oxygen in the tissues will be decreased. So if the unloading of the oxygen in the tissues will be decreased, tissues will get less oxygen, and as a result, the patient can also have a hypoxemia because of that, right? Hypoxia, not the hypoxemia, but the hypoxia at the tissues because of that.
So loading will be also compromised in the same, vice versa.
Of course, whenever you have a high affinity, loading will be decreased. Whenever you have a low affinity, loading will be, unloading. Whenever you have a low affinity, unloading will be increased. Whenever you have a high affinity, unloading will be decreased, right? See, more affinity, harder to dissociate the oxygen with the hemoglobin, right?
Yeah.
So if I have more affinity, can I have an unloading of oxygen now?
More affinity will be less unloading, right?
Exactly. With the left shift, with the high affinity, you will get the less unloading.
Thank you. Got it. Thank you.
Any more doubt on this page?
No, thank you.
Okay. Now, two poisonings, cyanide poisoning and the carbon monoxide poisoning. In both of the poisoning, the major thing that these two drugs or these two poisons do is to block the complex 4 of the electron transport system. And as a result, because the cytochrome C oxidase is now blocked, the oxygen cannot be utilized to form the water, right?
Right.
If the oxygen cannot be utilized to form the water, you cannot have the ATP production. Okay, you cannot have the generation of the this energy, and as a result, when the cells do not get the energy, they will die, right?
Right.
So hypoxia at the tissue sites will happen, and again, if you give the patient 100% of the oxygen, you cannot correct this condition. The hypoxia cannot be fully corrected by giving the patient 100% oxygen. Although the hemoglobin is normal for now, okay, the saturation will be normal, because if you are having a carbon monoxide poisoning, when you measure the pulse oximeter, the oxygen saturation, it will show normal. I told you, right?
Yes.
So although the hemoglobin is binded with the carbon monoxide, the pulse oximeter will show you a normal. And if you give the patient 100% of the oxygen, okay, or a supplemental oxygen, it again won't correct this saturation, because this carbon monoxide has an extreme high affinity for my hemoglobin. Okay.
Yes.
So no matter how many how much concentration of oxygen you give, still it cannot compete with the carbon monoxide. Okay.
Yes.
For my cyanide poisoning, although it does not bind to the hemoglobin, but again, it will cause the inhibition of the electron transport system by blocking the complex 4. So the saturation of the oxygen will be normal, but it just my tissues cannot utilize this oxygen now, right?
Yes.
In both of the conditions, because the oxygen is not available, the tissues will use the anaerobic metabolism pathway. So as a result, the patient will have a severe lactic acidosis, high anion gap metabolic acidosis. You will see in these patients. Okay. Patients on the skin findings, they will be having a pink or cherry red skin. Okay. The patient can also have a seizures and coma because of these two poisons. Okay. So the cyanide and the carbon monoxide poisons. The treatment for the cyanide poisoning, you can give the patient hydroxycobalamin. Okay, hydroxycobalamin, which is a vitamin B12. And this vitamin B12 will bind with the cyanide instantly, converting it into the cyanocobalamin. And this cyanocobalamin, it cannot be reabsorbed in my tubules. And as a result, you will have a renal excretion of this cyanocobalamin. The second thing is to give in patient nitrites. And these nitrites will process the oxidation of the hemoglobin, convert it into the methemoglobin. Okay, and I told you, the methemoglobin will bind with the cyanide, converting into the cyanomethemoglobin. Okay, and this cyanomethemoglobin is kind of less toxic. Although toxic is there, the toxicity is there, but again, less toxic. So better than having nothing, right? One is always better than having zero, right?
Yes.
Yeah.
Other thing you can give is the patient this sodium thiosulfate. Okay, and this sodium thiosulfate donates its sulfate group to bind with the cyanide to become the this thiocyanate. And again, just like the cyanocobalamin, this thiocyanate will be excreted by the kidneys. So please note, sulfur group will be donated by this sodium thiosulfate. Okay, and the sulfur group will bind with the cyanide to become the thiocyanate. So this is about the treatment for my cyanide poisoning. Symptoms. First of all, patient will be having a severe lactic acidosis, hyperventilation will be there, high anion gap metabolic acidosis will be there, cherry red skin will be there. Headache is a very important symptom you will see in the patients. Patient will also have a bitter almond odor. Okay. The patient will be having a cardiovascular collapse. Very important. Okay. So these things will be seen in case of my cyanide poisoning. Okay. The curve of the oxygen hemoglobin dissociation curve will be absolutely normal. Okay. And the oxygen saturation may even appear normal initially. Okay. So no changes in case of saturation of the oxygen. Any doubt on the cyanide poisoning?
Excuse me, where can we find the resources of cyanide? Where can we get it?
So you can find the in the in the apple seeds. Remember,
Okay.
apple seeds has a very high rich source of the cyanide. First of all, okay, apricot seeds can be the source. Okay,
Yeah.
so these are the
I
sources
mean,
where you get this cyanide poisoning.
okay.
Yeah, apple
Okay, thank you.
seeds, apricot seeds. Okay, amygdalin. These are all the sources of the cyanides. Okay.
Okay.
You don't need to remember them. Okay, don't worry about that. It just you will encounter the patient and then you will see the symptoms and they will ask you about this oxygen saturation and all. They won't ask you the source. Don't worry. Okay.
Oh no, I know that, but maybe the scenario will mention that he's a farmer or like that, so you can get it as a clue.
Sorry, I didn't understand you.
I know that they will not ask us about resources, but maybe the scenario of the question says that
Okay,
a
CV.
patient is
Okay.
a farmer, or so we can get a clue from that.
Yeah, you can get a clue from that too, right? Absolutely, you can get the clue. Just remember, these
Yeah.
are the sources. Treatment is very important. 3 treatments. Okay, one is the hydroxycobalamin, second is the hydroxycobalamin, second is the nitrites, and third is the sodium thiosulfate. Signs and symptoms: headache will be there, CVS collapse will be there, bitter almond odor will be there, or this cherry red pink skin could be there, right? So these are all
Yeah.
the things. Now for the
We
carbon
don't give
monoxide, yeah,
we don't give oxygen and cyanide.
we don't get
We don't give oxygen O2
we don't get oxygen where?
and cyanide toxicity. Do we give the patient O2
Sorry,
like in
I
CO
couldn't understand.
poisoning?
No. You won't get it like that. Okay. These two are
Okay.
different cases. You won't get it like that. It will totally different scenario. So in case of carbon monoxide poisoning, because generally it happens, in case of fires or car exhaust or gas heaters. So multiple family members can have a history of same things, right? Same symptoms can be there in multiple members of the family. Okay, generalizely it will happen like that. So it could be a patient who basically from a labor category, for example, and they use chimneys or some fire combustion to raise the heat, right? So because of that, because of this wood, it releases carbon monoxide. So when the patient sleeps like that, they can get this carbon monoxide poisoning. And most oftenly multiple family members will be affected in this case. So always look out for that. If multiple family members are there having the same symptoms, headache and this chai red pinkish skin, seizures, coma, that's how this could be a case of carbon monoxide poisoning. Okay.
Okay.
But the important thing is this carbon monoxide will competitively bind to the heme. Okay. So the most important treatment you can give to the patient is the 100% oxygen or hyperbaric oxygen. Okay. This will be given to the patient because it is a competitive inhibition. So this oxygen will competitively bind with the hemoglobin. Okay. Symptoms,
Yes.
headache will be there, dizziness will be there. Multiple individuals may be involved in a single family. Okay. And if you perform the MRI of the patient, what you will find is the bilateral globus pallidus lesions. Okay. This will be a bilateral lesions present in the CNS. Okay. And sometimes this condition can also be found with the, can also be found in case of cyanide poisoning, but most oftenly it will be seen with the carbon monoxide poisoning. Okay. Now, when this carbon monoxide bind with the hemoglobin, it will cause the less saturation of my oxygen with the hemoglobin, but the oximeter will show a normal saturation. Along with decreasing the saturation of hemoglobin with the oxygen, this carbon monoxide also increases the affinity of oxygen for the hemoglobin. Okay.
Yeah.
So two things will happen. One is the loss of saturation, and second is the increase in affinity. Okay. So if this is a normal hemoglobin, what you will find in case of carbon monoxide poisoning, that you will be having a low saturation. Okay. So saturation will be dropped onto maybe 50% or 60-40%. Okay. After that, as you can see, if this is a normal patient having a low saturation, for example, the anemia, okay, these patients will be having a left shift, right? Because of increase in the affinity. Yes.
Right.
So a left shift will be there. Okay, this one, and a loss of saturation will be there. These two things. Now, already you're having a low content in your body of the oxygen. Apart from that, because the affinity of the hemoglobin for the oxygen is now increased, the tissues will have even more hypoxia now, right?
Right.
So this again will cause the respiratory acidosis, this iron gap metabolic acidosis, lactic acidosis, and all these things. Okay. So treatment is very important. 100% oxygen should be given to the patient. Okay.
Can you repeat the process? Like, how does it decrease the saturation?
Sorry, what?
Can you repeat the last point that you have just discussed?
See, if you look at a normal hemoglobin of the patient, it has curve like this. Okay. This curve, normal 100%. Okay. When you get a carbon monoxide poisoning, the saturation of the hemoglobin for the oxygen is not dropped, right?
Yeah.
So let's say it become only 50%. So as you can see, the curve is not dropping to 50% efficacy only, right? Or 50% saturation only, right?
Yeah.
Now, if you look at the anemia case, I told you in case of anemia, the hemoglobin concentration is decreasing, okay, but the affinity of the hemoglobin for the oxygen remains same.
Yeah.
So let's say if there is an anemic patient and he's having a loss of 50% of the hemoglobin, so he will be having a normal affinity, right?
Yeah.
So a normal affinity at 50% saturation would look like this curve, distorted curve, right?
Right.
But I told you in case of carbon monoxide poisoning, you're also having an increase in the affinity.
Yeah.
So low saturation, and as you can see, the curve for the carbon monoxide poisoning is left shifted, right?
Yeah.
So an increase in the affinity and loss of saturation is what you see in case of carbon monoxide poisoning.
Right.
Okay.
Okay, thank you.
So I have a question.
Yes.
I want to ask, like, whenever there is decreased saturation of like carbon monoxide poisoning, so in that case, how the affinity will increase? Because there is another things like when there is a hemoglobin, there are the different parts. When there is a one oxygen get combined with the hem part, then the others again start combining. So here the carbon monoxide is replacing the
Yes.
O2. So despite that, there should be like body needs more oxygen. So hemoglobin should release those oxygen to the tissue. But despite that, it is not releasing and increasing affinity. What is the mechanism? How it works? I couldn't understand.
See, hemoglobin has nothing to do with this. Although the function of the hemoglobin is to carry the oxygen, but look at from the hemoglobin, this from the side of hemoglobin. Look at that. Okay. See, the hemoglobin is losing the oxygen. Okay.
Yes.
So the hemoglobin now wants what? You know, the hemoglobin wants more oxygen now, right, to replace this all this CO, right?
Yeah. Yeah.
So whether tissues are getting oxygen or not, hemoglobin has nothing to do with that. Okay.
It
He just want to maintain the oxygen level of its own. For doing that, he needs more affinity of the oxygen. Okay. See, the external effects are there. All this temperature, PCO2, exercise, 2-3 BPG, high altitude temperature, all of these things can affect the hemoglobin binding with the oxygen. But these changes are, all of these things, all of these components are totally normal in case of the CO poisoning. Okay. The external environment is totally normal. So the hemoglobin will think about itself only, right? Not about the body.
But when there will be hypoxia, they will demand, like body tissue will demand, despite it is
So yeah,
not
body
releasing
demand is
that.
increasing. Body demand is increasing. For that, the body can do only one thing, which is to release the EPO, right? The EPO will be released. Okay, all this these new RBCs will form. Okay, but
It takes
other
time.
than that, you won't have anything, right?
Yeah,
all these factors will remain absolutely normal. So only these factors can affect this change of the hemoglobin binding with the oxygen, right? Because these factors are totally normal, so these won't interfere. Okay. So think about the perspective of the hemoglobin. Everyone requires oxygen, and so does the hemoglobin also, right?
Yeah. So despite
hemoglobin only releases the oxygen in the tissues when you have these findings in the tissues. Even if you increase the pH of the tissue side, hemoglobin won't release the oxygen if you're having a hypoxia, right?
inadequate oxygen with them.
So it is the function of body to release the oxygen from the hemoglobin, not the function of hemoglobin itself. Okay.
Okay, thank you.
Okay.
Yeah, thank you.
Okay. Any more doubt on this carbon monoxide poisoning?
No, thank you.
Okay, now you have the pulmonary circulation, and let's take a picture of what happens when the blood enters into the alveoli. Now, as soon as the blood enters the alveoli, before the alveoli, what was the level of PaCO2, the partial pressure of CO2? That was around 40, right? At this point. Okay, this is what our hemoglobin has. This level of PCO2, this level of PaO2, and all these things. Okay, so the PaO2 is around 40 again, and the PaCO2 is also around 40. Okay, in the deoxygenated blood. What happens is, as soon as it enters into the alveoli, okay, because the oxygen is a perfusion limited gas, what happens is it will readily saturate with the hemoglobin. Okay, as you can see, the oxygen is readily saturating with the hemoglobin, right?
Yes.
And this is the partial pressure of the oxygen in my alveoli. So as soon as the blood passes one alveoli, okay, it will attain the level of oxygen in that alveoli, right? Very rapidly it will happen, as you can see, okay?
Yes.
And same thing happened with the CO2. This is a level of CO2 in the alveoli, and this is a level of CO2 in the blood. As soon as the blood reaches the alveoli, okay, the CO2 of the blood will attain the level of that alveoli, right? The same CO2 as that in the alveoli. So both of these gases, the PaO2 and the PCO2, these are the perfusion limited gases. That means they can easily cross this barrier. Diffusion is not the diffusion is not a limitation for them. Okay, if you increase the perfusion of the blood, you will get more oxygen. If you decrease the perfusion of the blood, you will get less oxygen. Okay, that means the perfusion is a limitation there, right?
Right.
Now, second type of gases are the diffusion limited gases. Okay, that means they have a slow rate of diffusion. That means the perfusion is not a problem for these gases, but the diffusion is. Okay, for example, the carbon monoxide. Normally, the carbon monoxide is a diffusion limited gas. Okay, if the barrier is thick or a barrier is changed, you will get a less diffusion. So that means less carbon monoxide. If a barrier is not decreased, okay, or something is increasing the diffusion of this gas, you will get more diffusion. Perfusion is not a problem for these gases. Okay.
Right.
So as you can see, this is the level of the CO in my blood. Okay. As soon as the blood reaches the alveoli, the level of carbon monoxide is slowly rising, not instantly, right? These levels are slowly rising because the diffusion is slow in this case. The diffusion is very rapid in case of my CO2 and PO2. And as a result, the oxygen and CO2 will be readily diffused around these barriers and will enter into the blood, right? As you can see, the speed is very fast. Okay.
Yes.
But the carbon monoxide is a diffusion limited, and as a result, it will take time to attain the levels of the carbon monoxide in the blood as that of the alveoli. Okay.
Right.
Now, when the fibrosis happen, or when the emphysema happen, or when you do the exercise, for example, in these scenarios, what will happen because of this fibrosis or emphysema thing? You will be having a decreased diffusion of this oxygen. Okay. Because of fibrosis, the thickness of the membrane will increase. Because of the emphysema, the surface area of the contact of the alveoli with the blood is decreased. So because of these changes, ultimately you will be having a low diffusion. And because of this thing, now the gases which were previously perfusion limited, now they become the diffusion limited gases again. So as you can see, in case of fibrosis, in case of emphysema, the oxygen will take time to attain the normal levels, the levels of alveoli, right?
Right.
So this kind of a scenario will happen when you get a this emphysema or maybe the fibrosis, for example, in case of interstitial lung diseases. Now, please note that the CO2 has a very high rate of diffusion. Even if the fibrosis happened, even if the emphysema happens, the CO2 can still having a normal diffusion. And as a result, the gas is still a perfusion limited gas, not a diffusion limited gas. Okay, so even though the oxygen is not diffusing properly in case of these diseases, the CO2 diffusion is totally normal. Is that okay?
Yes.
So note that fact also, very important. Okay. So
Mean that
normally
the
in case
body
of,
can
yeah.
the body can excrete CO2 normally in case of defect in the membrane.
The body can secrete CO2 normally.
Yeah, you mean that?
Sorry, what do you mean by that? Sorry, I don't understand.
When we say that CO2 is only a perfusion limited gas, it means that it only it does not affect by membrane damage.
Yeah,
Is that
it does
the
not
case?
affect. Yeah, exactly.
Okay.
It won't, it would be affected, but not as much as oxygen. Okay.
Okay.
100% change when happen to the oxygen, only 5 or 10% change will happen in the CO2 diffusion. Okay.
Okay.
So a slight change will be there. Okay, but not significant.
Okay.
Yes. Okay. So
Uh,
yeah.
So we are talking the perfusion and diffusion in respect to the RBC to tissue, right? From
We are discussing about the alveolar membrane here.
yeah,
Okay, the diffusion barrier, that is the alveolar membrane, the basement membrane, and the endothelial membrane of the blood vessels. Okay.
I mean to ask the diffusion from the RBC to the cell, not from cell to the RBC.
From alveoli to blood.
Uh, and okay, alveoli to blood. Yeah. Okay, so tissue to blood. Okay. Thank
From
you.
alveoli to blood. Okay, not from RBCs to tissues to the sites.
Mhm,
We're talking
mhm.
about the lungs here. Okay.
Yeah, I mean to say from the blood vessels to the tissue or tissue to the blood vessels. Alveoli to the tissue to okay.
Both,
Got it.
both will be there. Okay, both ways.
Mhm.
Okay. Now, see, I told you already the pulmonary circulation is a very low resistance circulations, right? And they have a very high compliance also. Remember, in the CVS we have discussed that already.
Yes.
So a low resistance circulations and a very high compliance circulation is your pulmonary circulation. Okay. Now, I told you also, whenever you have a hypoxia in the alveoli, what you will have is a hypoxic vasoconstriction, right?
Yes.
And this hypoxic vasoconstriction will prevent the blood from going to areas where the oxygen is not present. Okay. And that means it will shift the blood away from such areas to the areas where the oxygen is present right now. Okay.
Right.
So this will help in controlling the VQ mismatch in the patient. For example, suppose if there is this alveoli, okay, and this is a blood vessel, okay, this is, for example, normally I will get, some amount of oxygen here, and the blood is also here, right? Now, initially, let us suppose this is the ventilation and this is a perfusion. If I got a blockage, and in normal scenario, you will having a ventilation perfusion will be V by P. Okay. Now, if the blockage happens, then you won't get any oxygen, right?
Right.
In this case, if the blood is still flowing here, can this blood become, can this blood become oxygenated again?
No.
No. As a result, the ventilation is now zero, but the perfusion is there, right?
Yes.
So what you will have is absolutely zero VQ ratio, right?
Right.
Okay.
And all of this deoxygenated blood, this is the oxygenated one. For example, this will be 100% saturated, for example, say, okay, or maybe 99%, 95% saturated. Now this blood will mix with this blood now. And as a result, it will decrease the saturation of this blood. Okay, and let us suppose this is making the saturation around 50 to 60%, for example, only, right?
Yes.
Now, if this hypoxic vasoconstriction occurs, then the blood won't be flowing from that area anymore.
Right.
And as a result, all of this blood will go to other areas where the oxygen is still present.
Yes.
Yes.
So the blood, which was originally only maybe 95% or 96% oxygenated, this blood can now become 100% saturated, right?
Yeah.
Yeah.
Although still less than what is to be normal, but imagine somewhere around 100, not the absolute 100, but somewhere near to the 100. Okay. And now because a very slight blood is flowing through that area, only a slight blood will mix to this blood now.
Yes.
So as a result, the VQ mismatch, okay, the VQ mismatch will be controlled. It won't be zero. It will be somewhere near 1. Okay. And the saturation will be decreased, for example, say only 80 to maybe 85% saturation is still present. Only by 15% you have the drop in saturation. So the hypoxic vasoconstriction is a mechanism to preserve the VQ ratio or this mismatch whenever a blockage in your airway tract happen. So this will prevent your saturation. This will prevent the change in the VQ. Okay.
Right.
So this is a reason behind your hypoxic vasoconstriction. Again, you have two type of gases, the perfusion limited gases and the diffusion limited gases. Perfusion limited, as the name suggests, the perfusion is a limitation factor in these cases. And in case of diffusion limited gases, the diffusion of the gases is a problem or a limitation in case of these gases. In case of perfusion one, the blood flow is a problem. So, the diffusion of the gases happens very rapidly. Okay, they will achieve a level which is present in your alveoli, the normal pressure of your gases, very rapidly. Okay, so if you increase the blood flow, you will be having a more saturation, more amount of this oxygen in the blood, or maybe the CO2. If you decrease the blood flow, you will be having a low amount of these gases. In case of diffusion limited gases, the perfusion is not a problem, but the diffusion is. Okay, so these gases will take time to attain a normal levels, or you can say the level which is present in the alveoli, same as that in the blood, right?
Right.
So that was about these two gases. Now you have the equation that
Can
suggests, yeah.
sorry, can we have a little clinical scenario, like example of disease when there are perfusions and like monoxide beside this?
See, you have an emphysema and fibrosis, right, in your
Yeah.
lungs.
Yeah.
In this scenario, I told you initially your gases are perfusion limited. That means a perfusion is a problem. If you have more perfusion, more gas will be in the blood. If you have less perfusion, less gas will be in the blood, right?
Mm.
Now, in scenario where you got the emphysema or where you get any interstitial lung disease that is causing a fibrosis in your lungs, because these gases now become diffusion limited, the perfusion is not the problem now, right?
Mm.
These gases now will take time to diffuse from alveoli to the blood. So if you increase the blood flow, less time will be given to these gases for a diffusion, right?
Mm.
So less gas will diffuse to the blood and you will get a less oxygen in the blood, right?
Mm-hmm. Yeah.
So this is a mechanism of hypoxia in patients having emphysema or the fibrosis whenever they do any exercise. Whenever they perform the exercise, any patient of emphysema or fibrosis, they will have a low oxygen in the blood that will cause the hypoxia in these patients. So the fatigue will be there, okay, and all the things which you will see in the hypoxia will be there.
Asthma obstructive in those cases also will be the same scenario will be there.
Sorry, repeat again, please.
I mean, in the asthma or some aspirations, pneumonia, in
See, in the
those.
asthma, in case of your asthma, because it is an episodic condition, fibrosis is not there, okay,
Mm.
any damage to the alveoli is not there, okay.
Mm.
So only episodically you will get these things. Only episodically these gases become diffusion limited,
Mm.
okay. When the patient is normal, when the patient is absolutely normal, in between the episodes, you won't get to see these things in case of asthma, okay. Only when the patient got the episode, you will see this kind of a change from perfusion limited to diffusion limited in case of asthma only.
Okay, thank you.
So look for that patients. Okay, now you have a formula which is a diffusion of the gas is dependent upon the area of the diffusion multiplied by a coefficient of the diffusion multiplied by the partial pressure changes across the barrier, okay, divided by any thickness in the membrane, okay. So whenever you have a change in the surface area of this membrane of this diffusion barrier, if you have a more the surface area of the contact between the alveoli and the blood vessels, more diffusions will happen. Similarly, if the area is decreased, less diffusion will take place. If you change the thickness of the membrane, that means if you have a fibrosis, which increases the thickness of this membrane, you will have less diffusion. And similarly, if you get a less thickness or thinning of this membrane, you will get more diffusion. So in case of emphysema, where the area is decreasing, you will get a less diffusion. In case of a pulmonary fibrosis, the thickness of the membrane is increasing, and what you will get is again a less diffusion. Okay.
Yes.
And whenever you have a high blood pressure, in case of a pulmonary circulation, you will have a dilation of these blood vessels. You will have a leakage of all the blood, of all the fluid from the vessels. All that pressure, okay, will go backward and ultimately put the pressure on your right ventricle of the heart, on the right heart, and this will eventually lead to the right-sided heart failure and what you will call is a acute cor pulmonale, right?
Right.
So this thing can also happen again. Remember this fact. And you also want to measure the DLCO. Okay, this DLCO will tell you, how much the extent, how much extent this the CO can pass through these sacs. So this will tell you how easily a gas can be easily diffuses across these barriers. So for that, you will always maintain you will also check for the DLCO levels. Very important. Whenever you have a high emphysema, whenever you have a pulmonary fibrosis, the DLCO will be
Reduced.
exactly. And as a result, you will see when the DLCO is changing, when it is reducing, you will see that the patient is having a less diffusion. When the DLCO is increasing, you will be get more diffusion, right?
Yes.
So this is how the DLCO is very much helpful in determining the cause. Okay, so remember these scenarios. Whenever you got any fibrosis or emphysema, the oxygen will become a diffusion limited. So even if you perform the exercise, normally you're having this changes in the vasculature of the pulmonary vessels that will promote more oxygen in your body. But in case of your emphysema and fibrosis, because the gas has now become diffusion limited, if the blood supply to the alveoli is increased, you will get is a less diffusion. Hypoxia will happen with the exercise. So normally with the exercise, you won't get to see the hypoxia. But in case of the emphysema patient or a fibrosis patient, you will see the hypoxia. And step one will ask you why this hypoxia is happening in these patients, because the gas which was initially perfusion limited, now it becomes the diffusion limited. Okay.
Yes.
Can I say just that we have hypoxia and fibrosis or emphysema because O2 is a diffusion limited and we have membrane damage? Is it like that?
Yeah, exactly.
Okay. And when, give us an example that we have hypoxia because O2 is a perfusion limited. If they have obstruction, pulmonary embolism, like?
In case of embolism, you're asking what will happen to the gases, right?
لا, see, we say in emphysema and fibrosis, we have hypoxia because O2 is a diffusion limited, right?
Yeah, exactly.
And pulmonary embolism, can we say that we have hypoxia because O2 is a perfusion limited also?
Yeah, exactly. Less perfusion means less oxygen.
So that's it. That's O2 is both perfusion limited and diffusion limited. Depends on the pathophysiology we have.
Exactly.
Okay.
In a normal
thanks.
patient, in a normal healthy individual, the oxygen will always be perfusion limited. Only in a diseased patient, it will become a diffusion limited.
Okay.
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 Now you have the pulmonary vascular resistance, and for that, again, remember the pressure, flow, and resistance I told you. Remember, the pressure will be equals to flow into resistance. Remember, previous lecture we have discussed, I told you, remember this thing, pressure, flow, resistance in the same sequence. So the
Yes.
pressure will always be equals to the flow into the resistance. If you change this equation, you will know that the resistance will be equals to pressure divided by the flow.
Right.
So remember this equation, this will give you the pulmonary vascular resistance. Okay, so the P, this pressure here is a difference in the pressure in between the two ends of these vessels. So let me draw this. This is your this is right sided of heart. Okay, the right auricle, and this is a right ventricle. This right ventricle will pump the blood into the circulation, pulmonary circulation, and finally they will be received by the left heart, right?
Yes.
Again, the auricles and the ventricle. So at the one end of this circulation, you have the ventricle, the right ventricle. On the other end of the circulation, you have the left auricle, right?
Yes.
So in order for my blood to move from this right side to the left side, I need more pressure here than here.
Right.
As a result, what you will see, the resistance will be equals to the pressure in the pulmonary artery, or you can measure the pressure of the right ventricle. Both are absolutely same. Okay, minus the pressure in the left atrium divided by the flow. Is that okay?
Yes.
And if you guys have studied physics, then you also remember this formula. which is the resistance will be equals to 8 times the viscosity of the fluid multiplied by the resistance divided by pi multiplied by the cross-sectional area of the vessel.
Yeah.
So if you have more length of the circuit or this blood vessel, you will have more resistance. Similarly, if you have more viscosity of the blood, if more RBCs are there, if more antibodies are there, this will increase the viscosity. If the viscosity is increased, then the resistance will be offered, that this resistance will also be increased, right? The flow will be decreased ultimately. Similarly, if the cross-section area is increased, then more blood could be easily flowed and less resistance will be offered by the blood now, or the vessels now, right?
Yes.
So remember this formula. The resistance will be equals to 8 times the viscosity multiplied by length divided by the pi times to the this cross-section area powers 4. Okay. So that's about the pulmonary vascular resistance. Any doubt?
No, thank you.
Okay. Then you have the alveolar vascular this alveolar gas equation. Although step 1 won't ask you this equation, okay, you don't have much use of that. But remember that this equation will help you determine why this AA gradient is present. Okay, so this alveolar partial pressure of oxygen, this equation says that the alveolar partial pressure of oxygen will be equals to the inspired oxygen, the partial pressure of inspired oxygen, minus the arterial CO2 pressure, the partial pressure of CO2 in the arteries, divided by the respiratory quotient. And this respiratory quotient will be equals to the CO2 produced divided by the oxygen consumed. Okay, and this will give you this equation, which is 150 mm of Hg, which is the inspired air, the oxygen, okay, the partial pressure of oxygen in the inspired air, minus the arterial CO2 divided by the 0.8. Okay, and this thing will be C at the sea levels. At the sea level, the partial pressure of oxygen in the environment is 150 mm of Hg, right?
Right.
So this is the air you will inspire. So again, in the inspired air, you will be having a 150 mm of Hg oxygen. So this equation will determine how much PaO2 you will get. Okay.
Yes.
Now you have a AA gradient. Okay. Now let me make it for you. This is your alveoli. It has the partial pressure, which is P capital A O2. Okay. This is your blood. Okay. It has some pressure initially, which is P small a O2. Okay. That was before the alveoli. After the alveoli, it has again some PaO2 pressure, which is different than previous PaO2. Okay.
Yes.
And I told you, because this gas is a perfusion limited gas, it will radially get a normal level, which is the PaO2 in the blood. It will saturate the this hemoglobin with the oxygen, right? Instantly it will happen.
Yes.
So the PaO2, as soon as this vessel leaves the alveoli, it is equal to the PaO2. Okay, approximately. A slight difference could be there, but majority, it will be same as that of PaO2. Okay.
Right.
Now, some areas are there, in your lungs, okay, which does not passes through these alveoli. Okay, some areas are there which does not passes through the alveoli, and as a result, the deoxygenated blood there will remain deoxygenated, right?
Right.
So this deoxygenated blood, which again having a PaO2 of some level, okay, this will mix with this blood, right?
Yes.
Yes, and it will
And when
decrease
this blood, and when this blood mixes with this blood, it will decrease ultimately the partial pressure of oxygen in my blood, right?
Yeah.
So this
Yes.
change in this change of partial pressure of my blood, of my oxygen in the blood, after this blood leaves my lungs, when you measure that, you will get a difference in between the PaO2 in the alveoli and the PaO2 in the vessel. And this difference is known as the AA gradient. Okay, this happened because of the bronchopulmonary shunting. Okay, a shunt is there which does not pass it through the airways, and as a result, this deoxygenated blood will remain deoxygenated, right? This will mix with the oxygenated blood. It will make it more deoxygenated, which you will find here. You will get a difference in the PaO2, which means the blood in the arteries, and the air in the alveoli, and you will call it a AA gradient. Okay.
Yes.
Now the formula to calculate this AA gradient is age of the patient divided by 4 plus 4. Okay. So if a patient has an age of 40, okay, that means he will be having a normal gradient. This is plus minus 4. Okay. That means if a patient is having an age of 40, he would be having the AA gradient of around 10
Right.
to 14, right?
Yeah.
So this having a gradient level less than 14, this is very important. Okay. This patient of age around 40 years, he cannot have the AA gradient of more than 14, right?
Right.
If he has the AA gradient more than 14, that means this AA gradient is pathologic, not the physiologic. Physiologic is this one. Okay, it happens normally, and you will calculate this thing using this equation. Okay, if the patient is having a more than of this formula, if you estimate, for example, if you estimate the A gradient to be around 14 and the patient is having a A gradient of 16 or 17, that means the patient is having a pathologic A gradient, right? Not a physiologic one.
Yes.
So remember this condition. Okay, this was about the AA gradient. Any doubt? Please ask.
Do we have to remember these two formulas in the?
You don't have to remember this alveolar gas equation, but you do have to remember this age and the AA gradient formula. Okay.
Okay.
This one will be very important because they will give you a patient age. They will tell you the patient is having a this gradient of of this much. They will ask you if this is normal or not. If this is normal, question is over. If this condition is not normal, if this gradient is too much, then they can ask you about the cause. And by looking at the patient history, you will know what is the thing causing this AA gradient, right?
Yeah. Okay.
So this thing you will have to, for this way, you will have to remember this equation. Any more doubt on this page?
No, thank you.
Sir, this AA gradient may be present due to the because some alveoli are not well ventilated.
Sorry.
This AA gradient
Yeah.
can because of the some alveoli may not be well ventilated.
Yeah, it can also be happen like that because in case of your apex, sorry, in case of your base, okay, the alveoli which are present at the base, they have most oxygen as well as most blood, right?
Yes.
But the blood flowing through there is more than the ventilation. So again, some of the blood in the base remain deoxygenated again, and this will again mixes with this blood and again causing the A gradient. Okay.
Okay.
But the major role is again because of this bronchopulmonary shunting. This is the major role. Okay. Any more doubt?
No, thank you.
So let's take a short break and then discuss further.
Okay.
Yeah, okay, thank you.
Okay, let's discuss the oxygen deprivations. Okay, give me a second. Sure. Okay, so first you have the hypoxia, which is basically a decrease in the oxygen delivery to the tissues. Second is the hypoxemia, that means you have low content of oxygen in the blood. And third is the ischemia. It happens whenever you loses the blood flow to a certain organ. Okay, so first is the hypoxia, and that can be happen because of a loss of cardiac output. When the heart is not pumping the blood, RPCs won't reach to tissues, they won't deliver the oxygen there. Patient can have a hypoxia because of that. A hypoxemia, whenever you have a low content of oxygen in the blood itself, this will lead to again a low delivery of the oxygen to the tissues. So hypoxemia is a cause of hypoxia. Whenever you have any obstruction of the blood flow to the tissues for any kind of embolism or thrombus or maybe atherosclerosis or anything it could be, which will decrease the blood flow to the organ. This will again promote the hypoxia. Anemia, if we have a total of low this hemoglobin content in the blood, this will again causes a low oxygen in the blood. This will again causes a hypoxia. Carbon monoxide poisoning, which will compete with your oxygen binding sites on the hemoglobin, this will again causes a hypoxemia. So in all the conditions, you're ultimately having a low delivery of oxygen to the tissues, right?
Yes.
Okay. Now, second causes are the hypoxemia, that causes a decrease in the amount of oxygen in the blood. It could be because of two things. One is the normal AA gradient. Hypoxia happens when but the AA gradient remains normal. It can happen because of an increase in the AA gradient. So first, normal AA gradient, when the anatomical structures are totally normal, anatomy of your lungs or your blood vessels are totally normal. It just your that's a nice song. Let me yeah, okay. Now, first thing is when the AA gradient is totally normal, that means anatomy of your lungs or your blood vessels are totally normal. It just from outside you cannot inspire the oxygen. That can happen whenever you're on the high altitude. Whenever you're on the high altitude, the atmospheric pressure of the oxygen drops. So if the outside pressure of the oxygen drops, you cannot have the oxygen inside your lungs, right?
Right.
So this will again causes the hypoxemia. But the AA gradient is totally normal because I told you in order to get a AA gradient, you need a difference between the alveolar oxygen and the oxygen in the blood, right?
Right.
But because the alveolar already has a low oxygen, so if you check the difference, you will get a normal difference.
Yes.
Okay.
Yeah, here
So
in
the
high
first
altitude, we have
yes,
normal AA gradient, but both alveolar and arterial O2 is decreased.
exactly. We have a normal gradient, but the alveolar oxygen is decreased itself, and as a result, the arterial area is decreasing, right?
Yes, okay. Thank you.
So the first one is the high altitude. Second is the hypoventilation because of opioid use, because of obesity hypoventilation syndrome, because of a myasthenia gravis, for example. If the myasthenia gravis involves your lungs, okay, your skeletal muscles of the lungs, intercostal muscles, in that case, you cannot have the inspiration properly, right?
Right.
This thing again can promote the hypoventilation that can cause the hypoxemia, which is a normal AA gradient type, right?
Yes.
So if any condition is decreasing the amount of oxygen in the alveoli itself, that will be creating a hypoxemia, but with a normal AA gradient. In all of these other conditions, the oxygen in the alveoli is normal. It just the oxygen content of the blood is not decreasing. That can happen because of any VQ mismatch, because of any pulmonary embolism, for example, because of any damage in the in your in the diffusion barrier, for example. If any kind of a damage happens, for example, any kind of a fibrosis if happens, if COPD happens, okay, if you got a direct right to left shunt, for example, if there is a hole in the heart in the wall, if there is a right to left shunting present, okay, and that can be happening in case of, if anyone remembers, right
ESD,
to left shunt,
VSD.
AST, VST, or maybe uh, it could be due to a patent foramen ovale, right? Yes, patent foramen ovale.
Yeah.
Forget that condition.
Yeah, yeah, yeah.
Okay. Patent foramen ovale can also do that, right? So any condition which is directly transferring blood from right heart to left heart bypassing the lungs, that will again causes an increase in the AA gradient. In all of these scenarios, alveoli has the air, alveoli has the oxygen, but my blood does not have the oxygen because of some kind of a problem. In this case, the blood is not passing through the lungs. In this case, blood could be passing through the lungs, but the air might not be present at that part. Okay, it could be due to embolism, blood is not passing at all in that part of the lung where the oxygen is present. It could be due to a damage in the barrier of the air passage, right? So all of this thing can promote a AA gradient. It will increase the AA gradient. Any doubt?
No, thank you.
Third type, you will be having a ischemia. Okay, that can be happen because of embolism, because of a thrombosis, or because maybe of a decrease in the drainage of the blood by the veins. That can again cause these conditions, right? So all of them can cause a ischemia. Atherosclerosis can cause ischemia, right? So that was all the conditions due to which your tissues will suffer with a lack of oxygen: hypoxia, hypoxemia, and ischemia. Any doubt, please ask.
No, thank you.
How COPD causes high AA gradient?
See, in case COPD, you are decreasing the surface area of contact of alveoli with the blood vessels, right?
How?
In the because of damage of the alveolar septas. There's a pathology behind the emphysema, right?
Yeah. Yes, sorry. Yes.
Damaging the septa, decreasing the surface area, decrease the diffusion of gases.
Okay. I got it. So it's diffusion impairment. Thank you.
Okay. Any more doubt on this ischemias?
No, thank you.
Okay. Okay, so now you have three zones of the lungs. Let's discuss three zones. Okay, see, you have a gravity, right?
Yes.
Okay, you have a gravity, and this gravity has a more impact on this zone 3 than this zone 1, right?
Yes.
In this zone 1, because the pressure is low, air can easily enter to the alveoli.
Yes.
More pressure outside, less pressure inside, air can easily enter the alveoli, right?
Yeah.
On going downward, because of a gravitational effects, the pressure is quite higher on this lower end that and this upper end, right?
Yes.
So less air will inflow in these alveoli. As a result, these alveoli will have less distension, and these alveoli will have more distension, right?
Right.
Yes.
Now see, the pressure throughout these alveoli, throughout the lungs, is about, is approximately normal. Okay, you have PA here, you have PA here, you have PA here, same pressure. But because less pressure is present on the surrounding of this apex part, this alveoli will be more distended, this alveoli will be moderately distended, and this alveoli will be less distended. Okay,
Right.
same pressure on both these alveoli, on all three alveoli, but because the surrounding pressure is low on the apex and high in the base, the upper this alveoli on the apex will be more distended as compared to this base alveoli, right?
Right.
Now, what happens is, because of the distension, if let me draw this for you, you have the alveoli here, and you have the blood here. Okay, this is the PV, the pressure inside the vein, and this is the PA, the pressure inside the artery. For a blood to be flowing from this part to this part, PV must be higher than the PA. Is that okay?
Right.
And this is the PA inside. So in all these situations, the PV must be higher. Sorry, this is the PA, right? These are the pulmonary arteries and these are the pulmonary veins, right?
Yes.
So for any condition, in order for this blood to be passing from my veins, from my arteries to my veins, okay, this PA must be higher than the PV. Now in the apex, because of distension of this alveoli, it will obstruct the blood flow, right?
Yeah.
Yes.
And as a result, the PA is highest in the apex, followed by the PA, P small a, followed by the PV. Okay.
Yes.
This situation because of hypertension. Okay, this pressure inside this vein will be decreased so much. Okay, the pressure in the surrounding is already very much low in the apex, so the PA is the highest, followed by P smaller than the PV. This is about the zone 1. In zone 2, this alveoli is moderately distended. Okay, and the PA again will become more than this PA. Okay, the pressure in the artery will become more than the pressure in the alveoli in zone 2, because this alveoli is moderately distended only, and the pressure in the surrounding is more higher. Okay.
Yes.
So PA followed by the PR, this alveolar, followed by the venous pressure. In the zone 3, because of high pressure, these alveoli are not distended. And as a result, the blood can easily flow without any obstruction, without any this resistance. And in this case, the PA is again highest, followed by the venous PV, which is the this pressure inside the vein, followed by the pressure inside the alveoli. So this is about the zone 3. Any doubt?
No, thank you.
So please remember about these 3 zones. In the zone 1, the P alveolar is highest. In zone 3, the P alveolar is minimum. In zone 2, first you will have the atrial PA, then this alveolar PA, and finally the venous PV. Okay. Now, because of this gravity will affect both my air as well as my blood, right?
Right.
Because of this gravity, I will have a less blood in the apex than the base.
Right.
Is that okay?
Yes.
That means on going from base to apex, I will have a loss of blood flow because of gravity.
Yes.
This gravity will also affect the air, oxygen, right?
Right.
But not as much as blood, because blood is has much more weight than this air, right? So
Right.
although both are affected, but this gas is not affected as much as this blood, right? So as you can see, from going to base to the apex, the oxygen concentration is dropping, the blood flow is also dropping. But at the base, the blood flow is more than the ventilation, right?
Right.
So ventilation is very less, blood flow is less. Okay. So sorry, we're talking about the base here, not the apex. So at the base, the air is there and the ventilation is there. Both the ventilation as well as the perfusion are higher at the base, as you can see, because from going from base to the apex, they both are decreasing. So they both are highest in the base, right?
Yeah.
But the perfusion is more than the ventilation, as you can see. So if I do a VQ ratio, what I will find, the ventilation is much lower than the perfusion. So I will have a very low VQ at the base, right?
Yes.
So this is a scenario of the base. You will have a very low VQ ratio. At some point in the zone 2, okay, in the mid level, I will have both the ventilation as well as perfusion equal to each other. And that will give me a ratio of 1, right? This will happen at the midpoint.
Yes.
At the apex, I'm having a low ventilation, I'm having a low perfusion, but the perfusion is extremely low as compared to the ventilation. So both are low, but the perfusion is much lower than the ventilation, and I will have a more VQ ratio at the apex. Okay.
Yes.
If you check the overall ratio of the VQ, what you will find overall at this lung, I will have a VQ of around 0.8. You have to remember this. Okay. The overall VQ of the lung is around 0.8. Okay.
Yes.
Now, what happens at the apex? Because of a very low perfusion and high ventilation, comparatively, at apex, you will be having a wastage of the ventilation. And the VQ is around 3 at the apex. At the base, you're having more this perfusion than the ventilation. So at the base, you're having a wasted perfusion, right?
Yeah.
So at the apex, wasted ventilation. At the base, wasted perfusion. 0.6 is the VQ at the base. So both ventilation as well as perfusion are greater at the base of the lung than the apex, but the ratio again changes in the conditions, right?
Yeah.
Now you guys know about the tuberculosis, the mycobacteria. It depends upon the oxygen, right?
Yeah.
Because
It's
it is
more in
the
the
it is
Obligated.
what kind of it is an obligate aerobe, right? So it cannot
Yes.
survive in anaerobic conditions or a hypoxic condition. So what you will see at the apex, because you have more ventilation than the perfusion. So whenever you have an activation of the tuberculosis, this activation always occurs at the apex, not the base, right? Whenever you see a secondary TB infection case in a patient, you will always notice that the patient is having a lesion at the apex of the lung, not at the base, right?
Right.
Yes.
And that because of a high VQ at the apex, because you have more ventilation comparatively. Although both the perfusion are low and this ventilation is low, but comparatively, ventilation is 3 times higher than that of perfusion. And as a result, this TB bacteria can easily survive there. So whenever the reactivation of this TB bacteria occurs, it will always occurs at the apex. Okay.
Yeah.
Now you have two extreme conditions. One is when the VQ ratio is totally 0. Okay. And the second condition is when the VQ ratio is infinity. Okay. Now this VQ0 will happen whenever you won't have ventilation, right?
Yes.
So in a scenario where a alveoli does not have any ventilation, but it has a normal blood flow, it has a perfusion. So no ventilation, but a perfusion. What you will call it?
0. VQ equals 0.
Uh,
An obstruction.
Obstruction, or you can call it a shunt, right?
Right.
Yes.
Because the blood is passing through these areas, through those areas where the ventilation is not present. So it will be similar as transferring a blood from right side of my heart to the left side without passing through the lungs at all, right?
Right.
Yes.
And
Or
you call it a
bypassing.
shunt. Yeah, bypassing, you
Yes.
call it a shunt, right? Now this infinite
Yes.
condition happens whenever you have the blood flow, whenever you have the this ventilation, airflow, but you do not have the blood flow. That means any case of embolism, for example, right?
Right.
Now this thing, whenever you have a ventilation, but no perfusion, you will call it a dead space. Remember the conduction pathway of the air?
Yes.
We called it an anatomical dead space. Why? Because it has air, but no blood to exchange air, right?
Yes.
Right.
So air is there, right? Gas is there, ventilation is there, but not the perfusion. So that's why you will call it a dead space or infinite. So these are the two extreme conditions. In between, you can have a VQ mismatch. Any scenario that occurs in between these two, you will always call it a VQ mismatch. You won't say the patient is having a higher VQ or a lower VQ. You will just call it the patient is having a VQ mismatch. Okay.
Okay.
So two extremes in between, everywhere you will have a VQ mismatch. Doesn't matter where the ventilation is more or the perfusion is more, what the ratio is more than 1 or less than 1, you will always call it a VQ mismatch, because the VQ match is 1 always. Other than 1, always a VQ mismatch. Okay.
Yes.
Now, whenever the obstruction in the airway happens, because the obstruction is present, or you can imagine it like this blood is directly passing from my right side of heart to the left side without passing through the lungs. So even if you give the air, the blood is not passing through these sides, right?
Right.
So even if you give the patient 100% oxygen, this does not improve the condition of my patient.
Yes.
Or the condition could be slightly improved, but not as much as it should be, right? A slight improvement would be there if this for example, if a foreign body aspiration happens, you will also get this hypoxia vasoconstriction and all these things, right?
Yeah.
So if you give a patient 100% oxygen, that will improve the condition of a patient somehow, but it won't get the patient to a normal level back again, right?
Right.
So a slight improvement will be there, but not a significant improvement will be seen in case of the shunt. While in case of the dead space, the blood was not there, but the oxygen was there, right?
Yeah.
Yeah.
So what happens is, the areas where the oxygen saturation is not still 100%, if you give more oxygen, then more oxygen will be diffused to that blood. See, let us suppose this is the one alveoli and this is the second alveoli. You have a blood flow here. Now you get a dead space in this case where you get an embolism in this blood, okay? Because of this embolism, this blood cannot go in this direction, right?
Right.
But this blood has to go somewhere, right?
Yes.
So all of this blood will be diverted to this side.
Yes.
So this area, okay, this area, initially it has a V, it has a Q, but now the Q is increased, right?
Right.
Yes.
The V is same, but the Q is increased. You are getting a VQ mismatch. To counteract that, if I give a patient 100% oxygen or a supplemental oxygen, I'm increasing the ventilation here.
Right.
So again, if I increase the ventilation in this scenario, can I get a normal VQ?
Yes.
Yes.
So in this scenario, 100% oxygen will improve the patient's condition. But in this scenario, in case of any obstruction in the airway itself, I cannot improve the condition because even if I give the patient 100% oxygen, I cannot supply the oxygen to those areas where the oxygen is not present at all, right?
Right.
Yeah.
So those areas will still remain hypoxic at any cost, right?
Yeah.
So this is a
Also,
huge difference. Yeah.
the pulmonary vasoconstriction will play a role here in the obstructed side, right?
Yeah, it will play a role. It will slightly improve my VQ, but not, not very much significant thing. Okay.
Okay.
I still need a normal level which cannot be achieved even after giving this 100% oxygen. If I give patient 100% oxygen and a normal level is achieved or near normal is achieved, I can call it the patient is not having any shunt or maybe some other condition. But if the patient is having shunt and I give him 100% oxygen, conditions will be slightly improved, but not anywhere near normal. Okay.
Okay.
That thing will help you determine whether the patient is having a shunt or not. Okay.
Okay.
Any doubt?
No, thank you.
So that was about the ventilation perfusion mismatch. Now, any doubt again, please ask anyone on this page.
No, thank you.
And now you have an important case, which is the oxygen-induced hypercapnia in COPD. See, what happens in a COPD patient, they have a chronic hypoxia, right?
Yeah.
And they have a chronic increase in the level of CO2 also,
Yes.
right? Because of this chronically increased in the level of CO2 and decrease in the level of oxygen, the peripheral receptors in the body of that patient, they will start responding to the oxygen instead of the CO2. Okay.
Yes.
Please note, I'm talking about the peripheral receptors, which are two. Remember the iotic and the carotid receptors and this chemoreceptors, right?
Yeah.
So these receptors will start responding to the oxygen instead of the CO2. So because a patient is having a low level of oxygen, initially without any supplementation oxygen, the patient will be having a high respiratory rate, okay? Or you can say the hyperventilation will be there, increased respiratory rate because of low oxygen, right?
Right.
As soon as I give them the oxygen level will be increased in these patients, and as a result, the receptors will not responding to the oxygen anymore. Or initially, what will happen because of rise in the level of oxygen, the receptors get activated and they will cause a drop in the respiratory rate of the patient. Because low oxygen means high respiratory rate and high oxygen means low respiratory rate, okay?
Yeah.
So as soon as give them the supplemental oxygen, a hypoventilation will occur in these patients. That will again promote the high CO2 levels, right?
Yes.
So this is a one cause of oxygen-induced hypercapnia in COPD patient. Second thing, because of this increase in the oxygen, what you will have is an exchange or a displacement of the CO2 from the RBC by the oxygen. Because you have a relatively high oxygen now, this will enter into the RBCs, and in the RBC, what they will cause is the oxygenation of the hemoglobin, right?
Right.
And whenever the oxygenation of the hemoglobin occur, you will see that in the later chapter that they will release more H plus and more CO2. Okay.
Yeah.
You have the bicarbonate, which will be converted into CO2 back again. So again, this will promote more CO2 in the blood, right?
Right.
So there is a second thing. So these two things importantly, what you will have is a more of the this CO2 in the blood. Okay, so this will cause the hypercapnia in the CO2. Very important. Okay.
Yeah.
And the third important thing is when you give the patient the CO2, those areas which are having a hypoxia, they will start dilate. So initially when you're having a low oxygen, you will be having a hypoxia induced vasoconstriction, right?
Yes.
So this thing will be preventing the flow of blood from those areas where you have low oxygen, right? But as soon as you give the patient oxygen therapy, okay, this hypoxic vasoconstriction will be over. The vessels will dilate, but still the air is not present in that areas because of some kind of a defect, some kind of a damage. Okay, these areas cannot get the oxygen. Okay, but because of the supplemental oxygen, the patient is having a vasodilation throughout the vessels, right?
Yes.
So the blood will be going to these areas where the air cannot be exchanged. And if the air is not exchanged, can I have this excretion of CO2 from those areas?
No.
So if I do not have the excretion of CO2, that means I cannot have the, sorry, because I cannot have the excretion of the CO2, that means I will have the retention of CO2 again.
Yes.
This will again promote the hypercapnia in these patients. See, the air is not available, but the blood was available in that case. So what I will call it?
Shunting.
Shunting will be there, okay? So this again will promote more hypercapnia in these patients, okay? So three reasons. One is because of a shunting of the blood to these areas, to the low oxygen areas. Second is the release of CO2 by the RBCs because of a displacement of this bicarbonate and this H plus by my this O2. And third thing is a response of peripheral receptors to the oxygen. These three things will cause a hypercapnia whenever I give the patient supplemental oxygen. So whenever I just encounter a patient having a COPD, a chronic COPD, and I place them on a oxygen therapy, what I will see is the patient is having a more hypercapnia and hypoventilation as soon as I give them the oxygen. Okay.
Yes.
So that was the important thing. Please remember. Any doubt in this case?
No, thank you.
So that was about the oxygen-induced hypercapnia in COPD. Any doubt anywhere on this page?
No, thank you.
Now let's discuss the effect of PEEP therapy on the cardiovascular system. What is a PEEP?
Positive end expiratory pressure.
Yeah. Positive and expiratory pressure. Okay. Whenever you give the patient positive and expiratory pressure, what you will see is a decrease in the venous return. Okay. Second thing, there's a compression of the pulmonary vessels by the alveoli. Third thing, you will have a compression of the aorta. And fourth thing, the decrease in the pressure gradient across the ventricular wall. So first thing, you will be having a loss of venous return in the right ventricle, and as a result, the preload in the right ventricle will be decreased. Okay. Second thing, because of the compression of the pulmonary vessels, you will be having a high pulmonary vascular resistance. This will cause a decrease in the afterload of the right ventricle again. Okay. Because of decrease in the preload and a slight, this will increase the afterload, not a decrease. So because of decrease in the preload and increase in the afterload, you will be ultimately having a decrease in the left ventricular preload, right?
Right.
The blood cannot flow from right side to left side.
Yes.
And you guys can also ask a question, why this venous return is decreasing?
Because the vena cava cannot drain much now into the right ventricle.
Why?
Because vena cava, the blood has to flow from the abdomen into the thorax, and thorax is already having high pressure.
Yeah, because from my head and neck and because from my this abdomen, my blood needs to enter into the thorax. And because of this PEEP therapy, I'm already having a high intrathoracic pressure. So this will prevent the venous return to my heart, right?
Right.
So
And
again, yeah,
is this similar to Valsalva?
yeah, kind of. Yes.
Yeah. Okay.
Okay. Now, see, you're having a low preload and a high afterload because, if you guys remember the zone 1, I told you because of high pressure and low pressure in the surrounding area, these alveoli will be more distended, right?
Yes.
This will again cause a constriction of the vessels, as you can see here. Same thing is happening. Constriction of the vessels will happen, and as a result, the afterload will be increased. So you will be having a decreased blood flow from right side of the heart to the left side, right? So the preload of the left ventricle will be decreased. Okay, because the aorta lies in the thoracic cavity, a part of aorta is lies in the thoracic cavity. Because of increase in the pressure, compression of the aorta will also occur, right?
Yes.
Because of this compression, the baroreceptors will get activated. They will sense that the pressure is increasing, and when they sense that, the firing of these receptors will increase. That will cause a decrease in the mean arterial pressure because of vasodilation. So the left ventricular afterload will be decreased. Okay. Okay.
Yes.
Now, because the pressure in the thorax is increasing and pressure after this thorax in the aorta is decreasing, you will be having a less pressure gradient across the ventricular wall. And this will again cause a low afterload. Because low blood means low afterload, right?
Could you repeat this again?
See, you need a pressure gradient to flow the blood, right?
Yes.
Because you're having a high intrathoracic pressure, okay, the pressure change across the ventricles in the aorta and in the ventricle itself will be decreasing. Because both the heart as well as the aorta is present in the thoracic cavity, if I increase the pressure there, both will be affected, right?
Right.
So this will maintain a pressure, this will increase the pressure because of the compression of the aorta and change in the pressure in the ventricles, the gradient of the ventricle across the ventricular wall, this will be decreasing again. Okay. Because of decrease in the gradient, I will be having a less blood in my aorta now with each pump, right?
Yes.
So because
I
of
have a
less
question.
yeah.
Sorry. How is the gradient decreasing? Like increase in the intrathoracic pressure would be same for both ventricle and aorta, right?
See,
But
if you guys remember the cardiac tamponade, in this, in that condition, you will be having an equalization of the pressure of all the chambers, right?
Yes.
Same thing is here. Two chambers, one is the left ventricular wall and second is the aorta. Because of increase in the pressure surrounding both of them, the pressure is increasing. That will cause a change in the pressure in both of them and maintain the pressure. It will cause an equalization of the pressure in both of the sides. Okay.
Okay. Okay. Thank you.
Okay. In that case, you will be having a less blood. So ultimately, ventricles will be ejecting less blood into the aorta. Second thing, you're having a vasodilation. This will cause a drop in the afterload that will promote more cardiac output, but ultimately you will be having a fall in BP.
Yes.
Okay, so these are the changes you will see whenever you put the patient on a PEEP therapy. A high cardiac output, but a low blood pressure in the patient will be seen. And that's all happening because of a decrease in the blood flow from right side of my heart to the left side. And second is the vasodilation and decrease in the cardiac, this less blood flow. Although cardiac output is ultimately increasing, but low BP you will see. Okay.
How cardiac output is increasing?
Because of loss of afterload.
But preload is also decreased.
See, it's all a relative condition. Okay. Preload is decreasing, but so does the afterload. Afterload decreases more than the preload.
Okay.
Okay, both are decreasing, but again a relative condition. More afterload loss than the preload loss. So ultimately, more blood could be ejected. Okay. Any doubt on this therapy, PEEP therapy?
No, thank you.
Now you have the carbon dioxide transport. You can transport the carbon dioxide into three forms. One is the bicarbonate, second is the carbaminohemoglobin, and third is the dissolved form. Okay. And please note, this carbaminohemoglobin, it does not compete for the oxygen binding site. CO2 has a total different sites of the binding sites on this hemoglobin other than the oxygen. Okay, two different sites. Okay.
Yes. Okay.
Okay, so sites are different, not that of oxygen. Okay, different sites. So the majority form is the bicarbonate. Second most common is basically the CO2 itself, which is in the hemoglobin, binded with the hemoglobin, and the third will be the dissolved CO2. Okay, now what happens is at the tissue site, okay, because of increase in the H plus and the acidic environment there and increase in the 2,3 BPGA, you will loses all the oxygen to the tissues. Okay, and all of that CO2 will be diverted into the RBCs from the tissue sites. Okay,
Yes.
when this CO2 enters into the RBC, it will meet up with this carbonic anhydrase. And if you guys remember from the renal lectures, the function of this enzyme is to combine these two and to form up this carbonic acid, right?
Right.
Now this carbonic acid will be dissociated into the H plus and the bicarbonate, right?
Yes.
And this again creates an equilibrium state. See, you have the conversion of CO2 and H2O into this H2CO3. At the same time, this H2CO3 will again be dissociating into the CO2 and H2O. Similarly, this H2CO3 will be dissociating into the H plus and HCO3 minus, and this H plus and HCO3 minus will be combining to form the this H2CO3. A equilibrium state will reach when this forward reaction will become equal to the backward reaction, right?
Right.
Now, this is a stabilized condition. So, tell me, if I remove this H plus from this reaction, can my reaction has more forward than backward?
Right.
Similarly, if I remove this bicarbonate from the reaction, can I have more forward reaction than the backward reaction?
Yes.
That's exactly my RBCs does. What they will do is they will combine this H plus with the hemoglobin and they will make this HHB. Okay.
Yes.
Now, because you're removing the H plus from the RBCs, forward reaction will take place. Okay. And as a result, more of the CO2 will be converting into this carbonic, this acid, and then to the bicarbonate, right?
Right.
Secondly, you also have this chloride shift. Okay, in which I told you you will have the pumps, and the function of this chlorine and bicarbonate pump is to always shift the chlorine inwards and the bicarbonate outwards, right? Opposite direction always.
Yes.
So again, because with the help of these pumps, you will pump out the bicarbonate into the blood and you will pump in the chlorine in the cell, this chloride ion in the cell, right? Again, you are decreasing this concentration of the bicarbonate inside the cell. So this will again promote the forward reaction, right?
Right.
So this is very important to know. Okay, this happens in your peripheral tissues, and this will again help in the unloading of the oxygen. This is the Bose effect. Okay.
Yes.
Now, in the lungs, opposite happens. Okay, in the lungs, because you have more of the basic environment there. Okay, this bicarbonate will be shifted inwards, chlorine will be shifted outwards. This bicarbonate, because oxygen is present, this oxygen will cause a dissociation of this H plus from the hemoglobin. That means this state. Now this H plus will combine with this bicarbonate to form more H2CO3, and this more H2CO3 when formed, it will promote a backward reaction. You will found more CO2, and finally this CO2 will be diffused into the lungs now. Okay.
Yes.
And this effect is known as the Haldane effect. Okay.
In the lungs.
In the lungs.
Okay.
In the lungs are having a Haldane effect. In the tissues, in the peripheral tissues, are having a Bose effect. And that Bose effect I told you, forward reaction, Haldane effect, backward reaction. Okay.
Okay. Yes.
Okay. Now see, ultimately, the concentration of all this HCO3 and all of these things, why you're having the high level of HCO3, is totally dependent upon this buffer action of this reaction. These are the buffers, right?
Yes.
So because of this buffer, because you're having, you can change the level of this H plus and HCO3 because of this buffer, you're having more bicarbonate. And that's how 70% of the CO2 can be transported as the bicarbonate because of the presence of this buffer only, okay?
Yes.
Okay, so the deoxygenated hemoglobin is a better buffer of H plus, as you can see. It is betterly buffering my H plus. As a result, I will have more formation of the bicarbonate. And as a result, I will have more bicarbonate in the blood. Okay, so this is the thing responsible for high level of bicarbonate in the blood at the peripheral sites. Okay,
Yes.
because a deoxygenated hemoglobin is better buffer for H plus. Now, majority of the CO2 is carried as a bicarbonate in the plasma that we have already shown it here. Okay, any doubt?
No, thank you.
Okay.
Sir,
Now the response, yeah.
CO2 will favor the unloading of oxygen, but it will not alter the affinity for oxygen.
Sorry, ask it again, please.
CO2 will favor the unloading of oxygen, but not the affinity for oxygen.
See, affinity for oxygen is already decreased in the peripheral tissues because of this acidic environment there, right? And the presence of 2,3-BPG. Affinity is already decreased, but not because of CO2, okay? Although CO2 is promoting this acidic environment, so again, it will cause this, this release of oxygen, but not as a direct effect, okay?
Okay.
Is that what you're asking?
Okay.
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 Yeah. So now comes the response to the high altitude. Okay. So whenever you go into the high altitude, what you will find is you're having a low atmospheric oxygen, right?
Yes.
If the atmospheric oxygen is low, then you're having a hyperventilation again because of low oxygen, right? Hypoxia, hypoxemia will happen with a normal AA gradient, remember? Last page we have discussed that.
Yeah.
Now, because of this low level of oxygen in the blood, your system will get activated, your peripheral receptors will get activated, and they will start responding to the oxygen. While doing so, they will increase your breathing rate. Okay?
Yeah.
When the breathing rate is increased, you will get is a hyperventilation. So first thing you will see is the hyperventilation. Because of this hyperventilation, you're ultimately removing the CO2 from the blood. You already have a low oxygen. So, you can't do much about this oxygen. But what your body can do, because this is a perfusion limited gas and you're having a more of the ventilation now. Okay, because of this more ventilation, more blood flow will be happening in the lungs. As a result, more transfer of the CO2 will happen. Ultimately, you'll be having a more removal of the CO2 from the blood, right?
Right.
So this thing will cause the respiratory alkalosis ultimately. Okay, so the first thing you will see is the respiratory alkalosis. This will cause the altitude sickness, headache, fatigue, nausea, vomiting, lightheadedness, insomnia. These are all the features of this altitude sickness that happens because of respiratory alkalosis and the hypoxia. Okay.
Yes.
Now, acutely, your body does not do much. Okay, but acutely, what happens is you will get a metabolic acidosis. Your body will try to remove all the bicarbonate stores, right?
Yeah.
So a compensatory metabolic acidosis will take place. Okay, very important to note. While doing so, your body has to inhibit the RAS system also, because RAS system promotes more reabsorption of the bicarbonate, right? No?
How does that happen?
What is the function of your RAS?
Maintain the blood pressure.
Maintain the blood pressure. And whenever I have more activation of RAS, what I will see in my acid-base balance? Aldosterone, what does this aldosterone do?
Hypokalemia and alkalosis.
Alkalosis. So what is RAS doing? Alkalosis, right?
Right.
So whenever I have the RAS, I will have alkalosis, which I don't want here. See, I have already respiratory alkalosis. Why would I need the metabolic alkalosis, right?
Right.
So again, the RAS system will be inhibited in case of this altitude sickness, okay?
Okay.
Because your body need to do the metabolic acidosis, compensatory metabolic acidosis. In doing so, it need to inhibit the RAS also.
Okay. Yes.
Okay, so RAS will be inhibited, please note. At a very acute time, when you're ascending in a very first or second day, RAS will be activated. But after that, after 1 or 2 days, the RAS will be inhibited by the body, okay? So that you can have a metabolic this acidosis. So a
Why
chronic increase in, yeah.
at initial stages the RAS is activated?
Because you need the blood pressure and the heart rate. Initially, you need the blood pressure, you need the heart rate, you need more blood flow in the body so that more oxygen could be delivered. But after that, for a long compensation, your body need to inhibit this RAS. Okay.
Okay, thank you.
Initially increases, then decreases. So initially, so you'll be having a chronically increase in the ventilation. Okay. So the metabolic acidosis is the one way to prevent this condition, altitude sickness. Now, because of this hypoxia, your body does what is they will have to increase the release of erythropoietin, right?
Yeah.
And when they release the erythropoietin, you will have more RBCs, so more hemoglobin. Although now the saturation of hemoglobin is dropping, but because more hemoglobin is present, you can again have somewhere normal level of this oxygen in the body, total oxygen, these levels in the body, right?
Right.
You can either have a concentration, more concentration, or you can either have a more amount, right? So I chooses more amount. Okay. Erythropoietin is there, so more hemoglobin. If more hemoglobin means more oxygen, although less saturation, but more hemoglobin is there, so you will have more binding of the oxygen with the hemoglobin, right?
Right.
Okay, so erythropoietin will be increased. So this will raise our hematocrit. Okay, 2-3 BPG levels will be increased because there's already a low oxygen in the body. So your body will try to compensate that. While compensating, they need to increase the BPG so that more oxygen could be released for the tissues. Okay, so what you will see is the right shift in the oxygen dissociation curve, right?
Yes.
Your cells will try to change again. Your tissues will have more mitochondria in response to that. More mitochondria means more use of the oxygen for the, because the concentration of oxygen is reduced now. So in order to compensate, I need more, more of these resources, right? So if I increase the mitochondria, if I increase my resources increased, in that case, I will have again, somewhere to normal conditions again. So either I can increase the concentration, I could get a normal thing, or I can increase the mitochondria or my RBCs, more delivery, more utilization, right?
Right.
So this mitochondria again will help. Renal excretion of the bicarbonate will be increased. Okay. To prevent this condition, to prevent this altitude sickness, what other thing you can do is you will promote this loss of bicarbonate, right?
Yes.
To promote this loss of bicarbonate, you can give the patient acetazolamide, dorzolamide. These are the carbonic anhydrase inhibitors. And if you go back to the renal section, we have discussed, I told you that the use of these agents is in the altitude sickness.
Yes.
Because they prevent this condition, because they cause the rapid loss of bicarbonate. So you will have no alkalosis. Okay. You will get this compensation very early. Okay. Now, complications, patient can have a chronic hypoxic pulmonary vasoconstriction. Okay, this will increase the resistance of the circulation. If the resistance of my circulation is increased, that will put a load on my right side of heart. You will have a hypertrophy of my right ventricle, right?
Right.
Patient can also have a right-sided heart failure because of that. Okay, so because of this hypoxic vasoconstriction, patient will be having a pulmonary hypertension. Because of this pulmonary hypertension, patient can have a right ventricle hypertrophy that can again lead to the right-sided heart failure. This is one of the complication. Sometimes sometimes unequal vasoconstriction happens in the lungs. If the unequal vasoconstriction happens at some points in the lung, you will have more blood. At some, and at some parts in the lungs, you will have less blood, right?
Right.
Now, if you have a vasodilation at some points, that means all of the blood which was going initially to other places, where the vasoconstriction happened now, all of that blood will be diverted to these vasodilated regions.
Yes.
So you will have a more blood flow in the vasodilated regions while a less blood flow in the vasoconstricted regions. Now, because of this irregular vasodilation or vasoconstriction, because of increase in the blood to other areas, you will have an edema also.
Pulmonary edema.
Yeah, pulmonary edema.
Yes.
So please note, as a complication, patient can also get a pulmonary edema in case of high altitude. You can mention that here. FA has not mentioned it. So pulmonary edema is also a complication of the high altitude. If the unequal vasoconstriction happen, then the areas which are vasodilated, all of that blood will go through these areas. That will cause a loss of, this filtration of the blood. More filtration will be there. So pulmonary edema will happen. So patient will present you with a history of shortness of breath. You examine the patient and you will find that the patient is having a crackles in the lungs. X-ray will be showing some densities in the lungs, but the patient is not having any kind of a fever or other things. So pneumonia is not there because there is no fever, but the patient is surely having a pulmonary edema. Step 1 will ask you why this edema is happening. It is happening because of unequal vasoconstriction. Okay.
Okay.
Okay. Other thing is, just give me a second. Let me check if I'm not missing anything. Yeah, because of this hyperventilation and low level of CO2, can my patient also have the syncope? Because I told you the blood supply to my brain dependent upon the CO2 levels, right?
Yes.
If I have less CO2, less blood flow. If I have more CO2, more blood flow, right?
Yes.
I'm having a less CO2 here, as you can see. So if the less CO2 is there, then less blood will flow to the brain. And as a result, you will be having a syncope also, right?
Right.
But I also told you one thing. When this PaO2 level drops below 60, the brain will start responding to the oxygen instead of the CO2, right?
Yeah.
So if the PaO2 drops below 60, in case of my altitude, then my brain start responding to these O2 levels, and as a result, the blood flow to my brain will be increased now.
Yes.
Because I'm having a more blood flow to my brain, can I have a edema also in my brain?
Right.
So patient can also have a edema in the brain also because of that.
Can you please repeat this point? Edema one.
See, the blood flow to the brain dependent upon two things. One is a CO2 and second is a PaO2. Okay, in a normal situations, my brain will be responding to the CO2 levels. If the CO2 levels are more, you will get a vasodilation, so more blood flow. If the CO2 levels are low, you will get a vasoconstriction, means a less blood flow. But if the O2 levels drop too much, below 60, then instead of the CO2, my brain will start responding to the oxygen now. Whenever the oxygen is losses, vasodilation will occur, more blood flow. When the oxygen increases, vasoconstriction, less blood flow. Okay. Now, because of this low oxygen, more blood flow will be there. If more blood flow, more pressure means more filtration. I will get a edema in the brain, right?
Right. Yeah.
Cerebral edema. So again, another complication, patient can have a cerebral edema also.
Okay. Okay. Thank you.
Okay. So these are the 2-3 complications patient can have because of a high altitude sickness or this high altitude. Okay.
Yes.
Again, with long terms also, patient can also have an angiogenesis because a hypoxia is there. And whenever you have a hypoxia active substances will get activated. Okay. And they will release the VEGF, and VEGF promotes more angiogenesis. So this is the other thing the patient will be having in their body. Angiogenesis will be there. Okay. So yeah, that was about it. And now please ask.
No, thank you.
Okay. And based on the cardiac output will be increased, heart rate will also be increased, sympathetic system will be activated, and this system sympathetic system will be increasing your cardiac output as well as the heart rate. But overall, the plasma volume of the patient will be decreasing because of loss of RAS, because the patient need to excrete all this bicarbonate. The plasma volume of the patient will be dropping, but the cardiac output and the heart rate of the patient will be increasing. Okay.
Why increase in mitochondria?
If you have more mitochondria, that means you can use more oxygen, right? Initially, if you're using only 100 molecules, now you can use 200 molecules. So initially I'm having 100 molecules of oxygen in my tissues. Out of these hundreds, I have 10 mitochondria to utilize. Okay. So I can use 10 of these molecules while the 90 of them are wasted. Okay.
Yeah.
In scenario of hypoxia, where I'm having a less or these oxygen molecules, I need to preserve these oxygens, right?
Yeah.
So if I only have 10 mitochondria, so if you see the ratio, initially it was only 10% of the oxygen utilization, right?
Yeah.
So let us suppose my oxygen levels are dropped to 50. So I can only use 5 oxygen, right? 5 molecules of oxygen, but I need 10. So how could I get 10 by increasing the mitochondria? You still not understand?
Yeah, got the point. Thank you.
Ultimately, you need the normal amount of this oxygen in the bodies, in the tissue, right?
Yeah, basically we are just storing the oxygen because
Kind of, yes, exactly. You're using more oxygen now, not kind of a storing, but you're using more oxygen. Instead of 10%, you're using 20% of the oxygen now. Okay.
Okay.
So more usage, less wastage.
Right. Okay.
Any more doubt on this high altitude sickness?
Where will be the oxygen hemoglobin dissociation curve in the case of higher?
Because of increase in the 2,3 BPG, ultimately you will be having a right shift.
Okay. Actually, I was confused in alkalosis part.
See, respiratory alkalosis, but metabolic acidosis also, right?
Okay. Initially, it is a later change, right?
Yeah, of course, it is a later change. See, with the acute thing, of course, we'll be having a left shift with the very acute, but generally you will measure it after 1 or 2 days only, right?
Yeah.
By that time, right shift it has been occurred. Okay.
Okay.
And yeah, that was more of these things about. Any more doubt?
No.
So let's take a short break again and then discuss the response of exercises.
Okay.
Okay. So we have discussed about this high altitude sickness and what is the response of your body against this high altitude. Now let's discuss about the response to the exercise. So when you perform the exercise, your body needs more oxygen, right?
Yes.
So in this scenario, all of the changes will happen accordingly to increase the supply of this oxygen to meet the body requirement. Okay. Now, when your body is exercising, the metabolic activity of your body is also increased. And as a result, more metabolism inside the cell will happen. So more CO2 will also be released, right?
Right.
Now, where does the CO2 released? In the artery or in the venous blood?
Veins.
Veins. So the major change in the CO2 levels will be seen in the veins, not in the arteries. Okay.
Yes.
Now, second thing is the oxygen consumption. Of course, because the metabolic needs of your body is now increased, so the consumption of the oxygen will be increased also.
Yes.
Again, this thing will be happen, increase in the consumption of the oxygen. Now, because all of the changes will happen accordingly to give more oxygen to your body, so that your body can meet their oxygen requirement. So ultimately, right shift will also be happen so that more oxygen would be released by the RBCs, by the hemoglobin.
Yes.
So right shift will also be occur. And again, this right shift occur because of increased in the CO2 production. So again, if you have more CO2, more acidic environment, more release of this oxygen. Okay. Other thing, because you're performing more metabolism. So because of this more metabolism, more acidic environment will also be generated in your body. Okay.
Yes.
So this acidated environment will promote more this dissociation of the oxygen from the hemoglobin. So you will have a right shift on the oxygen dissociation curve. Ventilation of your body, of your rate will also be increased. So you will be having a hyperventilation to meet the oxygen demand. Okay, ultimately the tidal volume will be increased. Okay. Now, other thing is the VQ ratio. Please note, because the oxygen level in your body is increasing, okay, in your lungs is increasing, the ventilation rate in your lungs is also increasing. So because of this high ventilation and high perfusion, ultimately throughout the lung, the VQ will become equal in the zone 1, in the zone 2, in the zone 3. The VQ will become equal. Okay.
Could you repeat this once again? How the VQ approaches one?
The ventilation in your body is increasing.
Yes.
And the perfusion in your body is also increasing. The gravity effects is only present when the blood is slow moving, right?
Okay.
When the blood is fast moving, then gravity won't affect that much.
Okay.
Okay, so because of this fast moving blood, because sympathetic system is now activated, you're having a hypertension throughout the body, right?
Right.
Blood flow is increased throughout the body, through the lungs, through everything. Okay, the cardiac output is increased, and hence the blood flow to the lungs is also increased. Because of this increase in the blood flow or this perfusion and increase in the ventilation, okay, you will be having the equalization of this VQ throughout the zones, zone 1, zone 2, zone 3. Okay, in all of these zones, you will be having a same VQ.
Okay, yes.
Okay, and please note, the VQ will increase to 1. See, I told you before that the average VQ in the lungs is 0.8, right?
Yeah.
Average overall VQ in your lungs is 0.8, I told you, right? This.
Yes.
So you see, the VQ throughout the lungs will be increasing and it will be approaching to 1. Okay, so ultimately, because the VQ throughout the apex to base is approaching to 1, overall VQ will become increased. Okay.
Yes.
Or individually, if you want to say that in the apex, VQ will be decreasing and in the base, VQ will be increasing. Right? Because a normal VQ of your base is 0.6 and in the apex it is 3. So ultimately at the apex, VQ is decreasing and in the base, VQ is increasing, approaching to 1 throughout your lung, right?
Yes.
Is that okay or not? Please respond.
Yes.
Okay. So ultimately VQ will be approaching to 1. That means VQ will be increasing. Now, because sympathetic system is activated, you will be having a more cardiac output. More cardiac output means more blood flow to the pulmonary circulation also. So pulmonary hypertension will also occur. Okay. pH will be decreasing because your body, your muscles will be releasing lactic acid. So patient will be having a high NR-gap metabolic acidosis again. And please note that this acid is releasing in the veins only, and as a result, the changes, the major changes in terms of your acidity and in terms of your CO2, this will be seen in the veins, not in the arteries. Okay. So the venous pH will be decreasing, but the artery pH will remain constant. Similarly, the artery CO2 will remain constant, but the venous CO2 will be increased. Is that okay?
Yeah.
So remember that also. So no change in the PaO2 or PaCO2, but the venous CO2 concentration will be increased. Venous O2 content will be decreased because more extraction will happen. If more extraction will happen, that means less content of oxygen in the venous blood.
Right.
Okay, so these are all the changes you will see with the exercise. Any doubt, please ask.
No, thank you.
So any doubt anywhere on this page?
Can you please repeat the VQ part?
What part?
VQ ratio, why it's uniform?
Yeah, the VQ ratio from apex to base become uniform. It will be approaching 1 in the zone 1, in the zone 2, in the zone 3. The VQ will be approaching to 1 from 0.8 overall. So ultimately VQ is increasing and approaching to 1 in the apex part, because the normal VQ is 3. The VQ is approaching to 1 in the apex. That means in the apex VQ is decreasing, in the base VQ is increasing. But overall, if you say that VQ is increasing overall, approaching to 1, because a normal VQ throughout your lung is 0.8 average, right?
Okay, due to more ventilation, but
Yeah. Repeat it again, please.
why it's becoming 1?
Why it is becoming?
VQ ratio, why it's becoming 1?
Why is it becoming 1? Sorry, I'm not able to understand you. You're asking why this VQ is becoming 1, right?
Yes.
Well, it's a body physiology. You're having more ventilation throughout the lung. You're having more perfusion throughout the lung. As you can see, the cardiac output is increasing. More cardiac output means more blood flow to the lungs also, right? And you're having a hyperventilation state. So more ventilation, more perfusion. So both things are increasing. That's why.
Okay. Okay. Thank you.
Any more doubt?
No, thank you.
Okay, so let's discuss the physiology that happens at a time of panic attack. Whenever a patient gets a panic attack, in the panic attack, the major thing is the hyperventilation. Okay, the breathing rate of the patient become very much increased. Okay, the depth of the breathing will also be increased. So a deep breathing and hyperventilation is what you will see in a panic attack. Because of this hyperventilation, the CO2 of the patient will be dropped. If the PaCO2 of the patient is dropped, that means the cerebral perfusion of the patient is also dropped. I told you, because your brain is responding to the CO2, right?
Right.
Because of that, because of dropping in the CO2 levels, the perfusion of the brain is also dropping, and what you will get is a neurological sequel. Patient can get a diffuse hypoxia can happen in the patient, weakness, blurring of the vision, syncope will ultimately happen, lightheadedness will happen, dizziness will happen in the patient, right? So, you will often see a patient passed out after having the panic attack, right?
Yes.
That's why it has happened, because of a loss of CO2 in the body. The patient will be having a low cerebral perfusion, and that causes the passing out of the patient. Patient will be having a syncope, right? I remember this also. We have discussed all the complications of this high altitude sickness. You will be having a mountain sickness, headache, nausea, vomiting, fatigue because of low oxygen. Patient will be having a cerebral edema because of low oxygen again. Lethargy, confusion, gait disturbances could be there. Pulmonary edema can also happen because of a uneven, or you can say unbalanced vasoconstriction. And as a result, at some places the vasoconstriction will be normal, but at some places vasodilation will occur that will cause more blood flow to that area, that will disrupt this alveolar membrane, and as a result more blood leakage will happen. And what you will get is a bilateral run crackles will be there, alveolar infiltrates will be seen, dyspnea and cough will be happening in the patient, but without any fever. If the fever is not present, that means patient is not having a pneumonia, right?
Right.
So that's how you know the patient on this high altitude is having a high altitude sickness complications. Let's discuss the pathology, and the first one you have is the rhinosinusitis. Okay, it is same just the sinusitis, which means you're having a blockage in the sinuses. Okay, you have the maxillary sinus, you have the frontal sinus. Okay, you have this mastoid air sinuses. Many sinuses are present in your face. Okay, and these are all the air-filled areas. Okay, whenever these areas got blocked because of any infection or because of any hypertrophy, okay, of these passages, what will happen? You will have an accumulation of fluid in this case. So as you can see, this is your orbit. Okay, and the orbit is filled with the fluid, right? With the eyeball has fluid. So on the CT or X-ray, you will appear as the filled areas. As you can see, they are opaque, right?
Yes.
Yes.
But the sinuses, because they are filled with the air, they are totally black out like that. Okay, they're blackish. But if they're filled with some kind of a fluid, you will see the opacification in these air densities, right?
Yeah.
As you can see, this sinus here, it is filled with some kind of a fluid because of a blockage. The patient is having a opacity in this sinus, and that's how it will appear. Okay, whenever the patient has a sinusitis, that means an inflammation in the sinus because of a blockage, patient will be having a pain, and pain will happen over that sinus area. So a facial pain will be present, nasal discharge will be present. If it is bacterial, the patient will be having a very purulent discharge. If it is viral, this discharge will be kind of watery and non-purulent. Patient could be having a history of fever, cough. Okay, facial pain is very important, fever is very important. Okay, the most common affected one is the maxillary sinus. Okay, while other sinuses can also be affected. You have the ethmoidal sinus, you have the frontal sinus, you have the mastoidea sinus. Anyone could be affected, but the majorly affected one are the maxillary sinuses. The most common cause is the viral infection. You will have a pain in the facial area, you will have a cough or a discharge will be present, and discharge will be watery, non-purulent. If a superimposed bacterial infection will happen, and that could be happen because of influenza, pneumonia, or Moraxella catarrhalis, in that case, patient can also be having a purulent nasal discharge. Okay. Okay.
Yes.
Now, as a complication, if the bacterial infection happen, this bacterial infection can also transfer to the nearby structures. Contagious infection, right?
Yes.
So because of this, because of a transfer of this infection to nearby structures, complications could be orbital cellulitis. If the blockage happens here, infection happens here, and this infection enters into the orbit, patient can get a orbital cellulitis. If this infection reaches to the brain, patient can also have a cavernous sinus syndrome. If the meninges are affected, patient can also have a meningitis. Similarly, if the mastoid sinuses are affected, patient can have a brain abscess also, temporal lobe abscess. If the frontal air sacs are affected, if the frontal sinuses are affected, patient can have a frontal lobe abscess also.
Yes.
So these are the complications of the sinusitis, cellulitis, syndromes, the sinus syndrome, maybe the meningitis, maybe the brain abscess also. Okay.
Yes.
Now, any doubt on the sinusitis?
Do we need to remember the anatomy of the sinuses, like their opening in the?
You just need to see a picture. Okay, you just need to see where they are located. Not the exact anatomy is important. Just know, just have a this a very simple idea is enough. Okay, that the maxillary sinuses are present above, after the orbitals, and the frontal sinuses are present above the orbits, ethmoidal, and all the sinuses are present in the center, and the air sacs are present on the, near your this ears, right? So basic idea is enough. Not the exact location is important. Okay.
Okay, thank you.
This will help you in finding the complications. Like if they told you that patient is having a frontal sinusitis, then you will immediately know that this patient could have this frontal lobe abscess also, right? Or if you encounter a patient having a frontal lobe abscess, they can ask you about, the most common location from this, from where this infection could be, is enter into that area. So it would be the frontal sinuses. You will immediately know that, right? So a basic idea you must have. Okay.
Yeah, okay, thank you.
Okay, then you have a nose bleeding, that is the epistaxis, you will call it. You will have two types of epistaxis. One is the anterior and second is the posterior. Okay, the anterior one will always happens in the Kieselberg plexus. And this Kieselberg plexus, it has the branches from the labial artery, from the ethmoidal artery, from the greater palatine artery, and from the sphenopalatine artery. So these four arteries, they will form a plexus in the nose in the anterior side in the septum. You will call it a Kieselberg plexus. Whenever the bleeding happens in this plexus, you will see an anterior bleeding from the nose. Okay.
Yeah.
Now, second type of bleeding can happens in the posterior segment of your nose, and you will call it a posterior bleeding, posterior epistaxis. And this can happen because of a bleeding in this sphenopalatine artery. Okay, so a bleeding in the sphenopalatine artery alone, okay, this will lead to a posterior segment bleeding or a posterior epistaxis. And please note, this kind of epistaxis is always life-threatening. A severe kind of a hemorrhage can happen in this region. And as a result, the patient can die because of that. The anterior type of bleeding could be cured with the help of the cautery. Okay. And if you perform the cautery, you can easily cure this anterior type of this epistaxis, but the posterior epistaxis cannot be cured with the help of cautery. Okay.
Yes.
And what does a cautery means?
Burning the vessel with heat.
Yeah. You will burn the vessel with the heat, and as a result, you will seal the blood supply there, right? So you won't have any bleeding. So please note, anterior epistaxis, you can treat it with the help of cautery, but the posterior epistaxis cannot be treated with the help of cautery. Other than the cautery, you can also give the patient the nasal packings could be given to control the bleeding. Okay. Most of the time, patient will try the nose picking. Okay. They will try the nose picking, nose pinching. Okay. And this pinching will help them in preventing this thing. If they have the bleeding, they will just pierce the nose, they will pinch the nose, and this will help in preventing the bleeding. Okay. So this is a home remedy the patient can try. On the OPD, you will ask the patient to first pinch the nose. If the bleeding does not stop, you will give the patient nose packings. If the nose packings does not help, you will give the patient cautery. Okay.
Yeah.
Now the causes includes, the most important one is of course a trauma. The other common causes includes the foreign body. Okay. Allergic rhinitis can do that. Nasal angiofibromas can do that. Okay. If a patient has a history of nasal picking previously, then they can have an increases. If a patient got a AV malformations in the nose, remember the Osler-Weber-Endo syndrome?
Yeah.
If the patient got a telangiectasias or a AV malformations in the nose, patient can have a hepataxis also there. If a patient got a loss of clotting factors, or patient got a loss of platelets, thrombocytopenia, for example, in that case, again, the important symptom is a nose bleeding.
Yes.
So again, the patient can have a nose bleeding. Okay. So the nasal allies will be compressed with the help of the hands. Nasal pinching you will do. Nasal pinching you will do. So this will promote. So this will cause that the stoppage of this blood. Okay. Other thing will be these nasal packings could be given. If doesn't help, you will give the patient cautery. So these three things. And please note, you will perform the silver nitrate cautery. Although not much important to remember, but just have an idea. Silver nitrate cautery notice given for the management of the epistaxis. Okay.
Yes.
What's the syndrome that you have just mentioned that might cause?
Osler-Weber-Endo syndrome or the hereditary hemorrhagic telangiectasia.
Okay.
Okay, you will see that in the CVS, last page of CVS pathology. It was written there. Okay.
Okay. I remember this. Yes.
Yeah. Any doubt on this epistaxis?
No.
Okay. Then you have the head and neck cancer. And what is the epithelium lining your head and neck structures inside oral cavity, for example?
Stratified squamous.
Stratified squamous epithelium. Squamous or columnar?
Columnar.
Yeah. Squamous epithelium. Okay, not a columnar epithelium. Squamous epithelium. Similarly, in case of your nose, it is also lined by the squamous epithelium. So most of the cancers that happens in the oral region or your nasal region, or you can say the head and neck cancers, they are most commonly of these squamous cell carcinomas. Okay.
Yes.
Now please note, because first of all, they're carcinomas, they're arising from the epithelium. So the most common location or path from which they can be metastasized is the lymphatics, right?
Yes.
So you will see the metastasis of these cancers via lymph. So if you encounter a patient having a cervical lymphadenopathy or having a bulging something on the neck, okay, or having a mass in the oral cavity along with this bulging something in the neck, you will immediately know that the patient is having a metastasis of this cancer via lymph nodes. And that's why the patient is having a lymphadenopathy in the neck, right?
Yeah.
So most oftenly, whenever you encounter a patient having a head and neck cancer, they will have a mass in the oral cavity or they will have a mass in the nasal cavity. Along with that mass, patient is also having some kind of a bulging thing on the neck. And if you see this condition, you will immediately know that patient is having a metastasis of this cancer. Okay. Now, please note the risk factors for the oropharyngeal carcinomas that happens in your oral cavity. Most of them are caused by the human papilloma virus strain 16 and 18. That is the same strain that causes the cervical intraepithelial neoplasias, right? CINs. and then the cervical cancer. Same strain 16, 18.
Yes.
And same 16 and 18 strain can also be caused the anal squamous cell carcinoma, right?
Yeah.
So whenever you see the carcinoma because of HPV, it is always caused by the 16 and 18 strains. Whenever you see the genital warts, it is most commonly caused by which strains?
6 and 11.
6 and 11. And whenever you see the skin warts, they are caused by 124 or 125. Okay. So again, oropharyngeal carcinomas, 16 strain. Alcohol can cause it. Tobacco smoking can cause it. Smoking can do anything again. Okay, so tobacco, alcohol, and human papillomavirus, they all can cause the oropharyngeal carcinoma. Now, for the nasopharyngeal carcinoma, please remember Epstein-Barr virus will cause it. Okay.
Yes.
Now, how will you differentiate between a patient having a nasopharyngeal carcinoma or a oropharyngeal carcinoma? On
Nasopharyngeal.
Besides,
just based on the symptoms, not even the examination you have performed, just the symptoms.
Nasopharyngeal
Alright.
carcinoma will be having a tubal block also, eustachian tube blocks.
Okay, that would be a very good yes. Any other thing
in
that you might?
oropharyngeal carcinoma, there will be like not dysphagia, but unable to swallow or to eat.
Well, unable to, yeah, of course, this could be also happen. So if you, yeah, but if you encounter a patient having a history of, if the patient tells that he cannot swallow anything, if the cancer is large enough, only then you can have this condition. Okay, if the cancer is large enough, this cancer, the oropharyngeal carcinoma, if it is large enough, the patient will be having a history of dysphagia. In case of nasopharyngeal carcinoma, the most important history patient have is a blockage of the eustachian tube. And because of that blockage, patient will be having a hearing loss. Patient will be having a fullness in the ear. He will be having a ear discharge again. Okay, because this tube will help in the pressure equalization in the ear, right?
Yeah.
If the
Yes.
tube is blocked, patient will have a negative pressure inside the ear, and as a result, this will cause a drainage of the fluid inside the ear, right?
Right.
So patient can have a history of otitis media. Patient can have a history of ear fullness. Patient can have a history of decrease in the hearing. So hearing loss with some kind of a mass in the mouth or in the pharyngeal region, you will think about the nasopharyngeal carcinoma. If the if the mass is there in the pharynx, but no blockage of the eustachian tube, most commonly it could be a case of oropharyngeal carcinoma. Okay, both of them are the squamous cell carcinoma also. Okay.
Yes.
Now, an important concept arises here, which is the field cancerization. What does this mean? Whenever you smoke tobacco, okay, let's suppose you have 100 cells in the oral cavity. All these 100 cells will be exposed to this tobacco, right?
Yes.
So in all of the 100 cells, for example, let us suppose 50 cells got mutated somehow because of this tobacco smoking. Out of these 50 cells, let us suppose 10 cells have developed the cancer initially. Okay, so this patient will come to your department. You will see the patient is having a cancer. You will remove it, and you have ensured that the patient is not having any kind of a metastasis yet now. Okay.
Yeah.
So you have removed the cancer. Okay. You have no metastasis. The patient goes home. After some time, years later or 2 years later, patient again come to your department with the same history, with the same kind of a mass. Although you have previously ensured that the patient is not having any residual lesion or the patient is not having any metastasis, but still the patient is having a recurrent oral cancer again. Why is this happening? Because the remaining 20-30 cells that have developed that mutations, now they have developed the cancer. Okay.
Yes.
And this is called the field cancerization, because the carcinogen always damages a wide mucosa. Multiple tumors can arise in that oral cavity. So if you see a patient having a multiple tumors in the oral cavity, or the tumors from different locations in this oral cavity without any sign of metastasis, you can think about the field cancerization. Okay.
Yes.
You
While
mean
if you see,
focal areas? It will be focal areas separated or diffuse, connected.
Focal areas will be there. You have 3-4 areas in the oral cavity that have cancer, while other areas are normal. Okay. But the important thing that you must remember is patient should not have any evidence of metastasis. If you see a patient is having a lymphadenopathy, if the patient is having a bulging on their neck or something like that, you cannot say patient is having a field cancerization. That means patient is having a metastasis from lymph nodes to other side of the oral cavity.
Okay.
Okay. So remember this thing, if the patient is having a lymphadenopathy in the neck, 100% chances are if the patient is having a metastasis. If you have no lymphadenopathy, no sign of metastasis, then you are having multiple sites with cancers. That means it is a field cancerization.
Okay.
Does this concept
And step,
applies to other carcinogens as well, like alcohol and?
of course, yeah, of course, it can be applied to other areas also.
Okay.
But
It's not
important thing is no metastasis should be present. Yeah.
okay. I was saying it's not specific to tobacco exposure. It's related to.
No. Yeah.
It can happen.
It could be. Yeah. It could be to anything, due to radiation, due to maybe all these chemotherapeutic agents could do that also, right?
Okay. Okay. Thank you.
Anything can do that. Now, other important thing, Stefan will ask you about the location of metastasis, the first lymph nodes. In case of nasopharyngeal carcinoma, okay, the metastasis first happened to the adenoid tissue, which is present just behind your nose. In the pharynx region, you have the adenoid tissue. Okay, and whenever you have a cancer in the nasopharyngeal region, it will metastasize to the adenoid tissue first. In case of oropharyngeal carcinoma, the tumor will metastasize first to the jugular nodes, okay, and then to the cervical lymph nodes. Okay.
Okay.
Yes.
So please remember jugular lymph nodes for the oropharyngeal and adenoid tissue for the nasopharyngeal. Any doubt about this head and neck cancer?
No.
Jugular
Then you
lymph
have the
node.
deep vein. Yeah.
Jugular lymph node are the same as cervical lymph node, right?
Yeah, they are a group of, you can say, the cervical lymph nodes is a group of male lymph nodes. Okay.
Okay. Jugular is one of them.
One of them is, yeah, jugular is one of them.
Okay. Okay.
You have submental lymph nodes. Okay, you have many other lymph nodes also.
Yeah, anterior cervical, posterior cervical, post occipital.
Yeah, exactly. So jugular lymph node is a part of this group. Okay.
Okay. Okay. Thanks.
Now you have the deep vein thrombosis, and I already mentioned it many times. What symptoms you will have for deep vein thrombosis?
Swelling.
Swelling will be there. Okay.
Hotness.
Hotness will be there. Okay.
Redness, warmth.
Redness will be there. Warmth, hotness. Okay.
Pain.
Pain, of course. Pain will be there. Swelling will be there, right? So whenever you encounter a patient, having a severe pain, swelling, tenderness, warmth, redness to the leg or to other part, to any part of the body, that means patient is having a venous thrombosis, right?
Yes.
Yeah.
Now, same symptom, redness, tenderness, swelling, warmth, can also be seen when a patient is having a cellulitis. So how we differentiate between a cellulitis and a deep vein thrombosis?
Fever. Patient will have fever.
Fever. Yeah, fever.
Cellulitis.
Because in case of cellulitis, it is an inflammatory condition. Patient will have a systemic signs and symptoms of inflammation, which includes a fever, right? Fever, fatigue. So if you're having a fever with same symptoms as that of deep vein thrombosis, that means it is a case of cellulitis. If DVT without fever will occur, that means it is a DVT, real DVT, okay?
Fever, you mean systematic fever, right?
What I mean is?
There will be hotness and DVT, right?
Yeah, hotness will be on the localized area only, right? The DVT part. While the fever is diffused throughout the body, you will have a warmth, right?
Okay.
Yes. So now let's discuss what are the risk factors for the deep vein thrombosis. The first one and the most important one is the stasis. After a long flight or a long drive, patient can have a stasis, and that can cause a deep vein thrombosis. And please note, most of the times whenever you encounter a case of pulmonary embolism, Step 1 will mention you that the patient is having a history of long flight or a long drive. It could be a truck driver. It could be a man on vacation. It could be a patient who just checked in a hotel after a long hour of flight. So most of the time they will give you a history of stasis, which is causing a deep vein thrombosis, and now the patient is having a pulmonary embolism. Is that okay?
Yes.
Similarly, a hospitalized patient can have a deep vein thrombosis again. Second thing is a hypercoagulability, defect in the coagulation. For example, a factor 5 latent can do that. Oral contraceptive pills can do that. In the pregnancy, I told you you're having a high level of all the clotting factors, right?
Yeah.
Yes.
You can have again the deep vein thrombosis because of that. Or you can see the case of antiphospholipid antibody syndrome. Remember?
Yes.
You can have again the clotting because of that. Other thing is the endothelial damage. Whenever the endothelium got damaged, your body will be, your vessels will get exposed there, collagen, and as a result, you will have a binding of the von Willebrand factor there, and then the platelets, and then you will have a clotting there, right?
Yes, extrinsic pathway.
Yeah, and that's why in case of your, this diabetes or any kind of inflammation, you're having the damage of the endothelium. For example, again, in case of atherosclerosis, you're having a damage in the endothelium, right? That will promote the thrombosis again.
Yeah.
Yeah. So these are the risk factors for the deep vein thrombosis, and you call it a Burkos triad. Other than this triad, patient can also have a hypercoagulable state because of a malignancy. If patient has any kind of a malignancy, okay, then in this patient, there will be an increased release of all these clotting factors somehow. And as a result, patient can have a deep vein thrombosis whenever they have a malignancy. So whenever you encounter a patient having a cancer, or now he's having a pulmonary embolism or maybe a renal infarction, you can think about a DVT because of this malignancy, okay?
Yes.
Okay.
So a classical case could be a patient, a cancer, okay? This patient will be having a cancer, and now suddenly the patient started having a chest pain, and finally the patient dies after this. So Stefan will ask you why the patient is died suddenly because of this cancer. So the answer is because of the deep vein thrombosis that is caused by the hypercoagulable state induced by this malignancy, okay?
Yes.
Now, whenever you have a patient with deep vein thrombosis, to confirm, you will run a D-dimer lab test. Because in this deep vein thrombosis, you're having a thrombosis, you're having a utilization of all these clotting factors. And whenever this happens, you will also have the damage of these factors, of these clots.
Right.
And what is the protein that causes this condition?
Plasminogen. Plasmin.
Plasmin, right? So plasmin will get activated, and plasmin will destroy all this fibrin and fibrinogen. Okay, and as a result, it will release a D-dimers that would be detected by your labs. So you will check if you're having a high level of D-dimer, that means you're having a clotting in your body. Okay. Other than thing you can do, you can check for the imaging. You will perform a Doppler ultrasound. In the Doppler ultrasound, you will check for the vessels if they're having any compression, and it's an important test of choice. Angiography can also be performed in the patient. Again, for the treatment, you will give the patient low molecular weight heparin or a normal heparin acutely, or you can also give the patient enoxaparin, which is a factor 10A inhibitors. For the prophylaxis, you will give the patient warfarin, right?
Yes.
Yes.
So mainly for the acute management in the hospitalized patients, you will use the heparin or the low molecular weight heparin. For the outpatient managements, you will give the patient anticoagulant like the warfarin. Okay.
Right.
So that was about the deep vein thrombosis. Any doubt, please ask?
No, thank you.
So any doubt on anywhere on this page?
No, thank you.
That was about the head and neck cancers that we have discussed. Okay, I told you the patient will be having a,
I have a question, sir.
yes.
So whenever there is a DVT, like there is a high chance to getting fever, and patient also get the fever. So is that clinically hard and fast rule that if there is a fever, then it is
Your voice is breaking too much. Actually, I'm not able to understand you. Your voice is breaking too much. Repeat it again, please. Slowly read. Am I audible?
Yes.
Yeah, fever is most often present in cellulitis. Yes, almost 90% of the times you will see that fever in the cellulitis. Sometimes come with a DVT. How? Sorry, I didn't understand this. Sometimes come with a DVT.
Sorry, I mean to say the cases sometimes present with the DVT and fever as well. Like so, like whenever there is hypercoagulability and
A case of
thrombus.
patient having a DVT with fever, you're asking.
Yes.
Sorry, I never encountered such cases, I think. Is there any question on the UWorld or maybe on any other NBME you're referring to?
I'll find and I'll let you know. Thank you.
Yeah, find the question and we'll discuss that, okay?
Okay.
There might be other hints present, but most often you won't see any fever in case of deep vein thrombosis, okay? But you will see the fever in case of cellulitis.
Okay. Okay. Thank you.
If you have a question, you can send it, okay? We will discuss that in the next class. Okay, the head and neck cancers we have discussed. I told you the first you will have these cancers, you will have two types, the oropharyngeal cancers and the nasopharyngeal cancers. The oropharyngeal cancers are most often caused by the human papillomavirus, strain 16 and 18. Okay, while the other causes include the tobacco and the alcohol. Okay, and please note, step 1 will ask you what structures can have this squamous cell carcinoma or what structures could be affected by this human papillomavirus. So please note it is the tonsils, base of the tongue, okay, laryngeal structures that includes the true epithelium. The true epithelium, because the true epithelium of your vocal cord, it is the squamous epithelium, while the false epithelium, the false vocal cord, it is having a columnar epithelium for the nourishment. Okay.
Okay.
Your vocal cords have two type of cords. One is a true cord and second is a false cord. The false cord is a real cord where the voice is generated, and that is a squamous cell epithelium. While the false vocal cord has the function to give the nourishment to this squamous cell layer, right? And it is made up of the columnar cells.
Okay.
So the this HPV virus 16 and 18 can cause the infection of this true vocal cord. It can cause a squamous cell carcinoma from this true vocal cord, but not from the false vocal cord. Okay.
Yes.
Similarly, that this cancer can happen in the tonsils. This cancer can happen at the base of the tongue. The patient will have most commonly the dysphagia, while in case of nasopharyngeal carcinoma, because of obstruction in the eustachian tube, patient will have a middle ear effusion will be present. Patient will be having a hearing loss. Patient will be having a discharge from the ear. Okay, but they're not having any kind of a mass in the ear or in the ear, or maybe any kind of a this purulence is not present in the ear, and that's how patient is having a clear fluid, okay, in the ear. So in the ear, so it could be due to a cancer itself. Okay.
Yeah.
And I told you in the case of nasopharyngeal carcinoma, it will be first metastasized to the adenoid tissue. In case of oropharyngeal, it will be metastasized to the jugular lymph nodes. Remember that this will be most important. I got question from submental lymph nodes, I guess. It was in the free 120 also, and the exact same question I got in the exam also. So please note about these lymph nodes in the head and neck. But they will give you a cancer who is present just below this tongue, and they will ask you where the first the first lymph nodes which will be affected, by this cancer. So they will be the submental lymph nodes in that case. Okay, because it is present just below your tongue, right? So submental lymph nodes in that case. So you have to remember from which part of your head and neck, which lymph nodes are drained the fluid from there, right?
Okay. Yeah.
So remember just majorly 3-4 lymph nodes you have to remember. First one is the submental lymph nodes. Second one is the jugular lymph nodes. Adenoid tissue you must remember, and two more were there. I'm not sure their name.
Vircha.
Spinal.
Verkovan are not in the head and neck. They are in the supraclavicle region, right?
Yeah.
Anyways, we will discuss that tomorrow. Don't worry. I will make a separate slide on that part from different part of head and neck where you can have a different lymph nodes drainage. Okay.
Okay.
But for now, just remember about these three ones. Okay, submental ones, which are basically draining the fluid from the tongue. Then the jugular ones, which are draining the other areas of your oropharyngeal cavity, and then the adenoid tissue draining from the nasopharyngeal cavity. Okay.
Okay, excuse me, doctor. Is this
Yeah.
notes from your ward or what?
Is it from what?
Those notes are from your ward?
These lymph nodes are, sorry, in UWorld it is only
No,
about
I
jugular
don't.
and the adenoid is given.
In general, I'm just asking in general, those written notes by your hand are your word notes or what?
Sorry, I'm not able
Am
to
I
understand
She,
you.
she's asking if these notes are from UWorld or not.
Oh, these three one. The two are from the
in
UWorld. The
general?
adenoid and these jugular are from the UWorld, but the mental I got it from the Free 120.
Okay, thank you very much. I appreciate that.
We will discuss them tomorrow. Don't worry. I will make a separate slide, a list of all these lymph nodes that you must remember for the step 1 about the head and neck cancers. So just wait for that. Okay.
Okay.
And so again, if you have encountered a case of this head and neck cancers, what next test you will run? You will see a mass. You will perform a biopsy on this mass, right? But first of all, what you will see on the gross examination?
Mass in the pharynx.
Mass in the brain. So what kind of a mass? How will you say that this could be a case of a squamous cell carcinoma or some other
Ulcer
mass?
and ulcer.
Ulcerations, yes. You will see the ulcerations, you will see the hemorrhagic mass, necrotic areas will be seen on this mass, right? So you have seen this kind of a mass, then you take the biopsy. On the biopsy, what you will see is the creatinization, right? You have the creatine pulse. You will have, all this. If it's a case of hemopapillomavirus, what other findings you will see?
Coilocytes.
Coilocytes. If it is a case of your, there's nasopharyngeal carcinoma, you would just see this creatinization, not any other thing. Okay. Or sometimes you can even see the intranuclear these lesions also, right?
Yeah.
Okay. So intranuclear lesions can also be present sometimes in case of this Epstein-Barr virus, other than this creatinization. Well, the most important thing is the creatinization you will always get. Any doubt on these cancers?
No, thank you.
No, thank you.
Okay. So I think we should wind up here for now.
Okay.
Okay.
Yeah. Okay.
We will finish this chapter, I think, tomorrow.
Thank you so much.
Do you
Thank you
please
so much,
upload
everyone.
the previous classes?
Yeah.
Previous classes recordings.
Okay. I will send them there. I
Okay.
think today. Yeah. Okay. I will send them.
Okay. Okay. No problem. Okay. Thank you.
Thank you.
Thank you, doctor.